difficult for the surgeons to go on doing open surgery on them. And I have done it before, but if you want to change the catheter, and we are doing open surgery like the mitral surgery in that side, we need to be careful because sometimes you can have a problem. We say old surgeon looking for the lowest cardiologist in this case, or surgeon doing very nice things. You must be careful what you want to do. Okay. So I decided in 2014 to go to this department in Germany, in Stuttgart, in Heart Center, and I learned how to do the minimal basic mitral valve surgery. For me, the first day was like simply understand how is it to operate the mitral. You understand? But the mitral is in the middle of the but it was, the first surgery was amazing. The second surgery was amazing. The third surgery, they were the same week, and this was the things for them, but there was no team. All they have said, they have all the cases, the rules, surgery. So, I then. Go to this one and find okay, we will go down to him, we perform the slides. You can see we perform under the breast and the other open the left atrium, and we can apply the same techniques that we use for the cardiac surgery. In this case, polarization that we were using a lot for in community. And my department was a very reference in my repair. So I understood that was possible. Not so also was possible, was better for the patient, but also was better to see the valve. So we have a very clear view of the valve and not that when we have a problem that's and the solution of this time was to make a small, an incision with the tractor. This is a different interpretation of the valve, and our approach now is a regular incision, so remote incision, and try to use the important concept also for cardiac surgery. As you can see here, we don't have a retractor, we are using an Alexa, and we have the camera in the same pole to operate the micro. That's what we are doing now. Okay, we have an arm track to hold the camera. System because in cardiac it's in place, not like that. We let people go the vein or the etc. So we can do the same thing. And we go with these techniques using this kind of pusher. The different that the non-pusher we are using the surgery, but also interesting to know how works every kind of okay, and preparing the mitral. So this is a patient with a mitral repair compared with a full surrounding. Not so only setting. The patient doesn't care about setting, was a fighter. He works after 2 weeks after the surgery. He has the nonsense. We'll spend 2 months without working. He is going back to work. But in 2 weeks, he was able to work again. And we also published this technique. Probably is the best, probably the only paper about the portal in cardiac surgery. The concept of the portal in cardiac surgery. So we go on our needs, our minimal basic cardiac surgery, mitral, cardiac, in cardiac tumors, anatomical text, acoustic coronary surgery, aortic, etc. I'm not going to put all the videos, okay, because it's not the point of this meeting or thoracic, but just to know every pathology demonstration that we are doing, how we do it. For the aortic valve replacement, we can do a right space, or we can do also an installation. This an installation. So we open at the beginning we open around 18 meters, now we are around 5. because we put the cameras in the femoral. But here at the beginning, we put a central cannulation. You see with the cameras and everything in another space. We were able, relative comfortable with safety, because here we have the hardline machine, so we are safe. We have a problem. Different than but I think we don't have anything important. We have a meeting, we don't have anything. But here we have the hard machine. So probably is better to do this kind of things. No say, and we need that. And as you can see here, we arrived at this kind of 5 centimeters incision for the outer pouch. Also, in the second space, is a helium, also as well. And with this kind of valves, that are rapidly valves, they dominate the species. So it's like a valve, they open the medial stent, and we put in place in this case for right traction. So it's interesting the evolution that is better than anesthesia. Also for extending the aorta, there is no competition until this moment. There is no tax, there is no anything for an ending of the aorta, ascending the aorta. So we can do an sternotomy, and as you can see, for the patient, this is how we are doing now. And this is of 5 centimeters of the ascending aorta. Also for cardiac tumors, as you know, they are not malignant. They are probably most of them are benign. But if you have this in the left atrium, you can have, of course, some problems with the mitral valve, and you can have a stroke because of that. Imagine this big mass in the left atrium. So we can do this by minimal invasive, also endoscopic, this big mass.
Se puede hacer con cámara
Or scanning zona.
no se le ve, yo tengo la cámara cerrada.
Yo lo estoy cerrando.
The brain.
Cuando entran, y les estoy recordando que lo vean por YouTube.
Also very good to prepare in heart, of the heart, and also coronary bypass. At the moment, we are doing just one bypass, but we are doing a condition here in the LED, and what we are doing is a mini thoracotomy in the left space, we keep the space in the left side. We retract with this retractor, this space will be more painful.
No, si paga las luces, no se ve el...
This camera.
Pero se ve la imagen.
Ah, sí, el video sí.
Las apagadas.
With the minimal invasive content might be to do the same surgery we will do in open for a small incision. Cannot be worse than the result, of course, because you are doing minimal invasive. This is the most important of the minimal invasive in any study. This is another case I'm not going to tell you about. Was a simultaneous working with the cardiology. So we put directly the stent directly through the coronary artery, and we put the stent, and we can dilate the distal part of the artery, and after we move to a bypass, and with this good result, all the stability completely rationalized. Also, we publish this. For antifibrillation, here my experience in thoracoscopic was very important. And here we open the pericardum, we use this camera, we use CO2 to have space, and with this acoustic, we put under the pulmonary veins, and we pass this device to burn the anomaly waves producing the atrial fibrillation. Also in the roof, also this kind of device, close to pericardium, and we go to the left side. So all of the experience in thoracoscopy and thoracic surgery were very important in my practice. And at the end, we use a stapler to reset the left atrial appendix. So Also in cardiac surgery, we use sometimes stapler. And another way is when you have to close just to an patient with atrial fibrillation, and you want just to close the left atrial appendage. We open that one. You can see the pericardium, and in this case, we are not going to use a stapler. We are using what they call a clip to close the appendix because it's the place where the close will be involved. So we put by also we can do it by doing portal. The problem is that in the side we don't have a lot of space to go to the left area. So we need the CO2 helps a lot of more space. Also, this kind of atrial septal effect. Not endoscopic with the camera in the same hole, as you can see, this is completely important. And we can prepare the pain. We are very used to use this kind of non-fusions. Okay. So what about the robotics? The robotics, as Diego will tell you after, we were thinking about the robotics, of course, with people talking about the robotics, but it was normal to go when we were doing only one incision to go to 5 holes to do a robotic surgery. It's good for the patient. It's healthy for the patient to do it. We didn't know. We didn't know. So the single port was a project that didn't arrive in time or the pandemic. And after the pandemic, they had an idea. So he told me, we must go for the certification for Intuitive. Because I think we can do it by 2 boards. So the fourth version of 5. And the first surgery we were together, I remember Diego and say Diego, in Spanish, and Juanes. Let's do it by one incision. We do like me, of course, we go under the 1,000 times. When we perform, we put all the arms in the same hole. What's the first report on robotic surgery? And after that, you will see we will be performing vertical. This is the technique. After the trocars evolution, had an evolution with the oral trocars. After that, he will tell you that he cut this kind of trocars to be less invasive, smaller, and you can see that many of complex surgery can be done by the local rats. And also, we do all these more environmental favors. And what about the cardiac? Again, what's happening with the minimal cardiac, but we began 3 years ago with the robotic products. And cardiac was happening. They were doing like this, incision plus 5 robots with the robot. So, and when you see the history of the robot, you know that the speech was designed for cardiac surgery. And also the first surgery has been done in the world was a bypass graft. And what's the law for cardiac surgery? The problem is that there was not a big evolution after it began in the beginning of the 2000 with plastics, with mitral valves and repairs and everything. So we decided to go in. I called my friend in Spain, Daniel Pereira. They are the only team doing robotic cardiac surgery in Spain. So in Portugal, we are the only team now. And we performed what we call total endoscopic robotic cardiac surgery. So doing this without incision. And I thought, okay, there are a lot of holes, but there is no incision. So we perform this, yes, without opening the muscle. So it's interesting. We published also this year this paper talking about the technique of the trocars, how the advantages will be. And we were very surprised the first mitral valve repair we performed with robotic, that the patient only lived 15 liters. Cardiac surgery, not because of the heparin and everything, and the stenotomy or we break some ribs, the patient is normally live 500, 1 liter, 2 liters, and nothing is normal. This is frequent. 15 liters, And then the child patient is the third day home, third day. In Barcelona, they are doing this, they have high volume, and in the afternoon, the patient goes to the work, and the next day he goes home. It's really amazing for a cardiac surgery. It's really a change. And I can show you a video of the first remote mitral valve prepared in Portugal. Let you know how it works. So as you can see, of course, you have the advantages of the road. The advantages has a lot of indications and a lot of advantages. For me, the most important of the robotic surgery is when you have to make sutures. Because in a bronchial sleeve, you have a lot of advantages with the robot because you can have this articulation of the robot that is not possible with our uniportal instruments. So in cardiac surgery, of course, we are always giving knots and putting sutures inside the heart. So the robot can be a very interesting thing. And for sure it is. This is a vision. We open the left atrium and say, wait, here we are putting that in a cord, then the leaflet of the mitral valve was a rupture. And we need to change many things. We cannot put a prosthesis or a ring, rigid ring through a trocar. So we put a balance in the suture. And also we lock, like we are doing robotic for the sleeve. And this was very, very interesting. It was really impressive the evolution of this data. Was the first base, we perform more cases. This is also a more complex case of SAD with the anomalous return of the pulmonary vein going to the cava. And in this case, we clamp the aorta, we open the cava in the right atrium, and we have a big hole that we need to put a patch. And again, if you need to suture, it's much easier to suture with the robot and suture with our straight instruments of minimal invasive cardiac. I like to do the example like the Playmobil. You know, you remember the Playmobil that we play like this. Maybe you're so you know, but we play like this. And after there were some toys that have articulation with the arms. But you have to suture much better. And also for coronary mammary. At the moment we are harvesting the mammary with the robot, that we have 10 times magnification of the image. You have no which is the lot of this. We have the stability of this very delicate to have the memory and after we perform the bypass as we perform minimal invasive. So again, I think the robot here has a lot of advantages. So what about the training? 100 years ago, Dr. Tasses said this famous phrase, do one, see one, do one, teach one. I don't agree with this. Maybe 100 years ago it's possible. You see how to take out the toolkit and you can go and infect that or infect it or something. Today it's a little bit different. So ideally see 1,000, 1,000, maybe each 1,000. Or on the other side, see many more, and teach many more. This is our belief of minimal invasive cardiothoracic surgery, also minimal invasive treatment, follow the innovation, try to use the best technologies, and compromise with every patient. The team is with Diego, me, another surgeon, also with Vanessa, it's a cardiothoracic surgery surgeon, mostly here, but we live yesterday. Working in Mallorca, and we are pioneers in portable surgery, in mitral valve, sympathectomy with a special technique with this, we're going to talk about after one, in portable valve and robotic cardiac surgery. And we are working again in this one in Algarve, in Portugal, and Porto, that after we came 3 years ago to Madrid, we have many patients there with Diego, Also in the Azores Islands, very beautiful, you don't know, I recommend to spend one week there, beautiful, also in Coruña and also in Mallorca. And our focus, one of our focus in this weeks is the training. And this is the calendar beginning in 2022, we have 3 courses, then in 2023, maybe 8 or 10 courses, and now for next year we have 13 courses. With 3 days or 2 days course, with lecture from basics to the top of the innovation, very important. Not to say that it's possible to do a double sleep with the portal. It's very important to teach how to begin to do portal. We are doing 2 or 3 courses, how to do the chest brain, how to do the first steps, just to the portal, everything is important. With that surgery and with the cadaver lab. This cadaver lab is interesting because it has a very good conservation. And they freeze the cadaver, and when they frozen, the organs are perfect, are really perfect. And of course, the anatomy is the same. So for us, probably is the best model to train surgeons. In African surgery, this is a video from Danny. Again, the same. Thank you to Danny for all your photos, all your videos, your support along these years. Thank you, Danny. This course was for cardiac surgery, but the concept is the same. Here we are training how to harvest the mammary and how to do the microvalve repair. This guy, he was my professor, now he works with me. Here, so you can see we have perfect tissue to put the prosthesis, to put the stitches. Also, we perform robotic surgery, live surgery. John, colleague.
Oh, yes, sir.
We have all the support of Scan always, so thank you always. And I was very happy with them finishing. I was very happy. I thought we are in the first line in cardiac surgery until I arrived to China. I arrived to China, we were conference with Diego, and had my hope. I knew what was happening in Shanghai in my hospital, of course. And we saw a new logo.
Tienes cómo escuchar ese audio. Tienes cómo escuchar el audio de la consola. El monitor va a ser. Sí, se escucha raro, pero
And also, we show in the program with the road
no
inside the
estoy
bottle,
seguro si estoy escuchando lo de ahí o no.
operating a brake inside the bottle. This is not possible with the lesion before arms. So you need an important process. And we perform first surgeries, which is though in May this year. The first surgery, no Diego.
Porque no sé si está funcionando, está con el micrófono de la compu. No está con el micrófono de la compu, creo. Porque yo hago bulla aquí, así sube.
Was a very nice experience. You can see this is the new
Hola, hola.
future of the surgery. This kind of broker goes in, the doctor is very fast, and you can put this inside the thorax. And also, I think that for cardiac will be amazing. Okay, we are waiting to arrive to Europe. That also for cardiac surgery will be amazing. And I asked to see a cardiac surgery department. I asked, where I can see some cardiac surgery minimally basic. This is the best surgery was done in the kingdom. The right Beijing and said, they don't want to see all the surgery. They don't want to see transplantation, they want to see minimally. They are very good. All right, we have no idea what I was to see. So this guy was doing 500 cases of minimum of robotic coronary bypass a year, 500 cases a year. 2-3 bypasses to robotic. You know what, I'm doing this in Europe. He said, oh my God, this guy was doing every day. So I was very impressed with this. And when we arrived in the second hospital was this building was all for cardiac surgery, 10 floors. They were doing 20,000 cardiac surgeries a year in one place. And the first day they were doing mid-cap, they were absolutely invasive. No one is doing this in the US. What they were not doing because I was there, they were not doing that. And also, And my God. Also, robotic surgery for since 2014. So, as you get to do a course here, and here, we perform the first minimal basic advanced cardiac surgery program. And the probably the biggest advance in the world. Again, same thank you to Danny for this amazing video. Very fast, so just to show you. For China, I don't know if you went for surgery. I recommend also the Shanghai course. But for cardiac, it's really amazing to see what they are doing in Hungary. The professor, for robotic surgery, minimal invasive, many things, interesting things working there. So, I didn't know this. I didn't know this slide was here. It was for another lecture I gave for Scanlan, and that is here. So, someone asking to me, with all this, what you are doing, what do you think about it? And I said, stay with my friends in Costa Rica and play the guitar. This is my really life. So thank you. Thank you.
That now, you don't come to plan together. Then you always do it on anything. But if you are trying to migrate to do it by a smaller company, in order to do the technical innovation, to use which type of
The problem of the long-term team is that we need more evidence. Yes, the make more, but I think it's very better. You're asking about put the cameras in the, I think it's not the necessary. When we have, now we are doing more and more with the peripheral calculation, also because we need more space in the model decision we are doing. And in China, so that 90% they put the calculation down. So if you are going to operate the product,
Que pudiera traer mi mesa, que se la puedo pegar aquí.
As they continue to look at cardiac surgery, the improvement of Tavi and perhaps femoral the video, the lab is going better and better. And it's video is go by development. On the other hand, invasive surgery is going to also better and better. What's the future? The problem is that the cardiac surgery has a very special mind. And I say that in the wrong way. Because they think they are best. Doing very big decision, like they also big decision in surgery. And when you began, they thought that the parents were not very well. They say, doing that. For a family, prepare a family. For a father, prepare a family more than a minimum is not. It's not that. Now, I think we are having surgery. I would like to do more structural radiology. And I always look at when we do that, we have to get a cardiology. I think go to the IVU room. As of course, they are in the motion. Probably the cardiac surgeon, after 10 or 15 years of the is massive should go in the beginning. I think it was reasoning about the ablation of the nose. The thoracic surgeon must go there Because I'm not really aware of the emotions. Still not necessarily. Yes, but that, the guidelines say that the stand or an extent is not a surgical procedure. They don't need that. They are generally the local anesthesia. So this evolution is really amazing. But now you have like a cardiac surgeon, you kind of complain about the tabs and everything and continue doing it. Because there are many surgeries that need to be by a surgeon, not by a TAVI or that is not possible.
Who will win, the TAVI or the minimally invasive TAVI solution?
I'm very difficult for the TAVI. But then there's still
Some people prefer that external.
that they do well.
They go when they have applications. I strongly believe medicine, you should not be doing any procedure that you cannot go up. You cannot solve the complication.
You cannot do a specialty just to deal with the complication of the
Yeah, my opinion is cardiac, not the living state that is the problem. And it's regularities of the cardiac surgery, not of the heart.
Happen with the stents, for an extent, happen with the pacemakers, happen again with the valves. Happen every time in the cardiac surgery, some go to the heart, saying, bring the bed because I will.
Do you think plastic surgery or maybe cardiac surgery also have to go to some kind of hybrid residency program, like you learn both the same?
I got it for the traffic. Yes. I also spent 1 year in the cath lab, learning how to do put stents. I did Europe alone and put some stents. The people say that you're kind of students, they want to know how to work with the catheters. Because a TAVI is easier than cardiac surgery, but you know how to work with a catheter. It's like an ablation is easier than cardiac surgery. You know how to do a fibrosis. You can derive 20,000 to knowing anything.
But the problem is that the patients coming first to the cardiologist,
Yes,
they will never
the
say
checks and
the patient to a surgeon, the cardiac.
I don't know what would happen with I think it's the wrong way to leave less invasive with the patient. There are cardiologists also. Okay, thank you. Thank you. Okay, so our next presenter is Martin. Of the Department of Air on American Boston. It's the fourth time of the year. So, we want to talk about how to deal with video. And so thanks for all the people who organized the meeting. I think it would be a good time to organize each year. So my topic is about how to do GTO. Why they not done, but first of all, what are the GTO? The incident cancer people. We learned a lot on the Chinese data, and we know that about 3,000 I need too much as much reason which we are just find like in screen problem. The GTOs are not every time homogeneous, so we are every time homogeneous. So we have some solid components inside, and I think each of us should know a lot about the simulation, because the simulation is a value which we are dependent on when to operate and how to operate and how. I will show you the next slide. So the biologists take these problems and design, and they make their own classification and that is they have 6 types of classification. So it's things called the solitary or solitary on, and we found out that television of times 1 to 4 mostly every stage of carcinoma. But the others 5, 6, so they are mostly in the lung carcinoma, which may be combined with lymphocarcinoma. So the last 2 types are the types which are more aggressive. And now, when we look at the lab of screening, which is coming, this is additional from here in ancient medicine, and here they describe the serum rise as categories. And here you can see the question, what was the what we find the is it like when we would have screening in our country, we have hundreds and hundreds of patients. I think if we look at the figure, it will be very clear that it's not the way we have more patients, the way we think about it. And if we take GTO, so we look at screening or major question. When we have to detect this GTO, this is very important. You see it, and then what type of dissection? We do a word dissection, we do a synaptically, what to do exactly. And the other point, we have the decision, whether to do the plan, but how to find the patient. We can calculate about what. So we should find how to confirm this So if we look at the NCCN guidelines, we can find out that for certain regions we have a clear here, and then you can see that only for a region above the 15 millimeter and smaller, we can go for 30. So other we have to go for those in 3 months and they follow up. What about the symptomatic one? The symptomatic again, doesn't seem to be and the small, so we don't care. More than 600 meters, again, they have a little component. And the features which are between 6 and 8 and above 8, so we can clear the cell. So we got the background and everything. These are more and more important. For these which are pure, so you can see the first decision to make and 6 months when you more than 2 millimeters, 2 millimeters, 2 centimeters, so 6 months. Less than 2 centimeters, so you have to go for longer screening, first 1 year and then for 6 months, 1 year and so on. Now, this is a big piece from Germany. This is a patient which was a resistant lesion. You can see it's very, very small one, 2010. Then lost, then 2016 again. The lesion is up for 2 millimeters. So in 6 years, it developed sizes. Actually, it's not bad. So it's only very small. And then 27 millimeters, and then 23, 34 millimeters. So it's growing, but the patient is sleeping, and she has no any muscle study. And then here we decided to make this expand. The patient has our hospital in March 2023, and CICICA Meeting were outpatient somewhere, somehow, and we don't know exactly. And now 2023 decided to be operating here all night. But you can see the patient now is 81 years old. So if you look here, 10 years ago, I think it will be more special. So now what to do? Should we make nothing lung function and so on. So now the decision, okay, which we have to decide. So the decision can make us a lot of problems in our clinical practice. How to deal with that? What to do exactly? And then when we decide right, so what type of section, I think it's a study of JSON made it much easier for us. And the 284 and 459, it is the one for two GPUs, which are located like this one on the outer third, and they have, as I told you, ratio is important, less than 0.25, and they are less than something over the two. When the region is very well, so you can use the working sessions. You don't need to do any significant for the school. But for the group of patients with a CT value between 0 to 5 and 5 and less than 2 centimeters or 2 centimeters, 3 centimeters region, you can do conversion section for these, and for this you can do so here, every time significantly and significantly for this, and then the first group is this group more than 2.5. It means the part of this region is more than 2.5 till 1. And less than 2 centimeters, so you go for 20 all the way. This is what we have nowadays, what we have seen with now working with. But if we look at this actual schema, we are looking at really to more aggressive image detection for chemical level and consult our going on, which is 1906 and 21.9 and 2.7. And here for the school, they say maybe observation is enough. And for this group, segment of wide stretch, so pretty much that's it. And for this group, we know now that this group will change. And here, the rate is why we enough. But I think if I look at this table and this study, and I look at the experience, the patients are short, it's not patient, as enough of the things that the patient carry on the whole inspection, I think this is enough. So it could be the future that we will not eventually look around less than 3.5 and less than 2. And if you write down the guidelines and guidelines say for pure air and more than 50% from yes, so we have to do significantly all over the section. So that's and guidelines say okay, for that, significantly it's not coverage. And if you make it, should have a good margin. It means a margin from the tumor to your paper line to be more than 2 centimeters or the same size of the tumor or more. So analytical detection. Now we come to the point how to find using I think there are a lot of problems because like before we study this too wide plan and for utilization or utilization for medical so that also utilization for environment and all the environment. These are guidance and very, very different. So, we are looking at the color and we can apply medication, we can apply intent, we can apply following, and we can get also some for this we other things can very fun. So we have to have some good parameters so that kind of one to five is the best of the way, but for the medication. And then we can medication, so maybe it's like 5 minutes, you have not medication, and you can see that it's very simple, and you can go there and eventually and there we can pretty much give you one so we can everywhere. And the top is very one topic you here and that you can one topic. And then you can go there so in this case, we are 2.3 now for the lesions which are deep inside of the lamina by a filter. So we inject the as this one, so you can see because the needle injected and we see and the it's a lesion a little bit deeper. So we inject the lesion itself and we inject also in correlation with two-dimensional and you can see exactly like this. And this is true. That is like really to highlight the one which you see here. And this is how it looks like. My friend was going to perform the first procedure 2018, and my last concern was okay, the pathology maybe will have problems with that or something else, and the pathology was very happy about it, so the parents will be okay. So I know exactly where I want to search and the ones exactly where they need. So I think that this also for the pathology will be and for the bigger how to find and look at the all here from the achievements which are and so without Roma, you can never find, somehow more information for some small or not, we can this is like big example for this patient. I do not a lot of people will say 6 months or 6 months in this case, and then we say for 6 months, but we decided on our and we can see for 3 months and much of section, I think everybody will agree, okay, how to find it. You want to find only the right one. I know that actually there are the right, you can find one that are and then you watch, and that's it, I find it. I think it's not right. I think for the section, the marking is very essential, but for synthetic to it depends where the people are. It's a people are and we have one function to ensure that this region is the exact one or not. For the there is no indication for the mark. So let's see the branch that this region is exactly right. We can make and things and that is okay. Experience and the second one is yes, the book of the personal marking will help. So we like here, so we reject group, so we know okay. Here, so we can take the subsegment or a small part from the other segment, but for this here, we can take like lots of data for
enough.
Empezamos a ver aquí.
So I think for us, it's very important to summarize that for GPOs will be new data. So maybe next year we will be not more thinking about any virtual section for this station or presentations. We are thinking just observation and like the things I presented, maybe 5 years later or 6 years later, okay, it's growing, we can remove it. For this part, we will not be doing locatories, just segmentaries or wedge section keywords. And for this part, we need converting to segmentation.
Estamos tratando de conectarlo con el porque oye, pero sí, sí, sí.
And I think so screens, the screen difference nowadays, the number of situations will be have a lot to do, but there will be a lot of things to do with these patients. And we are waiting still studies concerning GGOs in order to have a clear concept of these patients, and these concepts could be more and more conservative. Marking, I think, is necessary for GGOs when we are doing the work section, and when we do a segmentectory, it depends on the segment and the experience of the surgeon and the characterization of GGOs. Thank you for your attention. You can use, I think you can use even you, which I do, or you can use this link also to the link. So you can just inject it and repeat it, and that's it. You can do those. I think those are good.
For local, how long before the surgery is rejected? It has to be immediately prior, or just
I do try to inject it 1 day before. So I inject it and do the surgery after. So what I noticed, for example, for patients, we have more serious about more than 25 patients with this treatment, and there were 2 cases with one emphysema, it was like emphysematic one, and when we went inside, it was blue, and after, really, during the surgery, you could see how the blue disappeared. Only for this emphysema line, I don't know why. So this is one point. And the other point is, which is important, we were thinking, okay, what happens when we inject and we don't see it, because we inject only like 0.4 milliliters. So it is very, very little. And if this goes somewhere, you will not see it. If you inject 1 to 2 milliliters, it will be everything blue. So we put inside this blue, we put some contrast, and we make our experiment, and you can see, okay, it's injecting now. So we can compare it under X-ray.
Congratulations on the extraordinary presentation. I have 2 questions for you, Olivier. The way that you put it, the remark is with bronchoscopy. If you mix the virtual images with localizing the right point to mark, right?
I mean, you make a CT scan. And from this CT scan, the CT scan should have certain value. And this value allows you to have an exact anatomical 3D visualization. So, and then when you visualize, you make functional and this process is like navigation in the car. That's it. So when you have the navigation in the car, you get, okay, I want to go there, and you just drive to this point, and you go to this point, follow the line, and you put it's exactly like navigation.
2 days ago, we did live surgery by in which we put green, nothing green, in one patient. But we didn't mark it as that we wanted tomography. And we usually do it 1 or 2 hours before the surgery. And in this case, in the case of the live surgery, when it was marked, we wait, I don't know, 3 hours. It was a lot of time. The point was that when Diego was doing the dissection, the green, it doesn't mean was dispersed in everywhere. So my question is, what happened with the blue? You told us that it's the opposite.
It doesn't. It's really the lesion, and you can see it from the lesion which I cut with my hand. You see it. I think I can just go back to answer it to you.
How much maintenance do we put?
Look, you see? Exactly. And the surgeon was also some, I don't know, with a procedure, with positioning the patient, everything. It was more than 1 hour. And it look alike. And the pathologists are really happy because they go exactly to this blue why you don't go, as you said, instead of injecting blue, injecting this green. You don't stop it, and you can see it, and so, but I see why you go down that way.
Let's do it, because the blue method is now, they are not using it because it's supposed to have some rejection of that. We usually use one, and then I think it's like.
There are like 0.4 millimeters.
I had the opportunity to see this procedure, and it was like amazing because, like Michael said, they done it in the same part.
No está
and
echando
they put it in the
Recupera aire.
an hour, and then do the surgery. So I think it's good, and that's the leverage. And I think is, I don't know, even need like it's more, it's less expensive than the green, because this one we don't need all this inhibitors and all that. So I like this. I hope this is nice.
I think only 0.4 millimeters is really very, very little. And every time I'm concerned because when the nurse puts the syringe, so I say, okay, don't remove the syringe and put again the syringe. So if you have a little bit of air inside, so you should be really very, very careful. You remember, I was every time looking, okay, are they doing it well or not, so we should control it.
What do you do if the linear is more deep?
If it's a lesion for sample, I mark the lesion sample, so it's like where it is, and I go to the filter and mark 1 point to the filter. So I know the lesion is in this direction.
Do you mark the linear with the blue or with
With
white?
no, with blue, same with blue. And I see, okay, this is the way, and this is where the lesion is okay. I think one was like this, which is
We go so exact. Yeah, we usually do double marking with oil. In case that the oil marking or without, so we could also do the percentages. Everybody does.
yeah, I told you there are a lot of business and systems which we are doing since 2018, and we have good experience with that. And I think it's or any more questions?
So for our next lecture, we have for Soxy, it's the first time that joined us in Costa Rica. We are very pleased and thankful for joining us. He is the plastic surgeon of Victoria Hospitals and the Hospitals of Bristol and Western United Kingdom. He's one of the pioneers in the orthopedics in UK. We talked a lot about this increase of the techniques and just their issues.
Buenos días, thank you everybody, thanks to the team for the presentation. It's a wonderful here with the excellent course, and yeah, yes, okay. So I'm a research and plastic surgeon. I work in UK. Just to introduce myself, I work in UK since 2011. Used my time to do some fellowships and research as well. At the time, I was visiting for a couple of weeks in Romania, and since the end of this team, I'm operating. And I've been a plastic surgeon since 2011. I'm a single board surgeon, and 90% of my practice is cancer, in busy. think you got that's basically what we do, and in terms of segment technique compared to directly, we've got to go through these topics just to mention the difference between seasonal contracts, instrumentation, and syntax, what I've done so far. So, single segment technique can easily describe segment technique where we have to do more complex segment and the complex where we have to do more complex segment plane. And this thing is described very nicely by the Japanese past. As a segment technique, we need to look at the bottom of the circle is force hook where the German is described for all the most common and uncommon variants. Then the reason as well why the Germans most of us in faculty have been taking part, which is taking part of that region. In terms of what we need to achieve as a segment technique, of course, we mentioned before, we need to do the same good job that we used to do one by now, that we used to do for the techniques. We need to have good margins. And then the things that have been highlighted in the past are perhaps economically, and then of course that, as you know, comes with the prolonged stay and more cost for the system as well to be more affordable for the patients. The concept of the distance between the node and the margin comes from this very large and interesting study from Japanese group. And of course, is the concept of at least the same size of the node to be achieved as margin. Then there is the latest European Society recommendation.
¿Se le está aplicando?
Which includes many good colleagues. There are several topics that maybe if you want to dinner we can discuss about these recommendations are mainly controversial, but of course it's something that in Europe we can this kind of practice. In terms of instruments, we mentioned all of that. To have advanced surgical instruments and stepping devices, energy devices, all available potentially in our theater. It doesn't mean that I open everything every time, but it means that if you need it, of course, you might want to remember what I have are advanced instruments and energy devices, which I think especially for the more complex segmentations are not mandatory but really useful kit and family meter camera, of course, if you want to. And then we need to start on the anatomy and be able to read properly CT scan and do the reconstruction. And then, of course, having a good plan on knowing which segment we're going to now to do that. So this is perhaps one of just to talk about this concept, maybe if you show the CT scan to a junior doctor, they might say, oh, this is segment 6, which is not. And that's something that, it's important, of course, to go through all of that really nicely when we plan a procedure. And then if you don't have a 3D reconstruction, we can use, of course, other tools. This is a good tool that is just free online. It's called Radiopedia, and is really nice reconstruction on the CT scan on the different segments. And I think for basic segments and even complex, it can be really good. And then, of course, 3D reconstruction system, if you have it, it's really useful. And again, to understand better the anatomy, to go through the potential aberrant vessels, and make sure that you are taking the right, of course, structures, which is really, really important for complex segmentectomies. The identification of the intersegmental plane, of course, there are different ways to do it, and the more you have tools, the better it is if you want, but if you want to stay basic, inflation, deflation system still works, especially if the lungs are not too emphysematous. And then ICG is quite common nowadays, and endobronchial dye, to be honest, it's a bit, again, controversial. Some papers are actually not recommending it compared to the ICG. But of course, all this technique, they have kind of limitations that we need to be aware of. And then, again, if the nodule is palpable, even if it's not really solid, it can be palpable sometimes, most of the times I would say, especially if you know where to go since the beginning. If you start touching around everywhere, then you're gonna lose your anatomy, I think. But if you know since the beginning from the CT scan where to expect the nodule to be, and you're careful, you most of the time you can find even GGOs, to be honest. And then normally I try to mark it either with a stitch or a cautery. The problem with the marking the nodule with cautery is that after a little while can sort of disappear, while if you put a stitch, that will be there, and you're gonna have your marking for later on when you have to do your intersegmental plane. I do use VATS instruments, and I use scissors as well, quite a lot, and energy devices. Of course, use whatever you're comfortable. You use basically translate the open practice into VATS, and that comes as well with more experience. Of course, maybe the juniors will prefer energy devices, but sometimes even a nice dissection with a scissor is really useful. And I really tend to do all the lymphadenectomy since the beginning to have my planes really nicely defined. And then normally, as we do mainly for the lobectomies as well, I go for the artery first, and then bronchus, and then vein at the end. The use of polymeric clips can be useful. You need to be careful when you use it in terms of you need to know how to use it. You need to have a good dissection all around of the vessel, otherwise it might get stuck, and then you are panicking because you are in a situation where you are not really comfortable. But most of it as well, especially if you're doing a complex segmentectomy using clips, you need to be aware that later on maybe you're going to pass a stapler line in that region, and the clip and the stapler line, they don't really like each other. So you need to know somehow when to use it. If you ask me why you haven't done that vessel with just an energy device, to be honest, I don't know. Probably now I would do it with an energy device, but is a really small branch that an energy device can take very easily. And you see here I'm struggling a bit. There is a newer devices of this one where the tip can be angulated. I don't have it. So that's why as well it's really good to have all your planes all around it well defined. And then I think I'm just cutting in between with the scissors here. Yeah. So they're useful. If you have it, you might want to use it if you don't have a small angulator stapler. And then as well for the vein, you need to remember that the structure of the vein is more collapsible. So the dissection needs to be done and you need to work it around nicely. And that was one of the comments I was making earlier on. I can't really see why you shouldn't do the vein when you're doing an apical segmentectomy. Is there? I can't really see why some recommendations don't include the section of the vein as well. And then here again as well, the more you remove all the lymph nodes around the bronchial segment, the easier it gets to go around. The bronchial segments are more collapsible than the main segment. They are more sort of flexible, and you need to have a good dissection all around, especially if you're using a big stapler to go around it. And that's basically nice and easy, even to go with a big stapler if you have done a good dissection around it. That's the vein. And again, in this case, you can see I'm using a 45 stapler, which per se for a segment, it looks like a gigantic. UK health system needs as well a bit of looking after costs. So sometimes you want to try to avoid opening extra instruments if you don't need to. And in this case, I used the reinflation system. As you can see, that was a segment 6 I was doing. And there is almost a really good intersegmental plane. This for being a British patient. Which namely are heavy smokers, and so lungs are never really that lovely. Apologies, that wasn't segment 6. This is a posterior segment on the left, I think. Fine. Anyway. Sometimes I use as well, and Mahmoud was showing it, the bronchoscope intraoperatively, just to follow with the bronchoscope the right bronchial segment. And either you have a good anesthetist actually knows the anatomy, or you're asking for the monitor to be looked at your way, so you direct the anesthetist with a bronchoscope where actually you want to go. And that helps sometimes if you're not absolutely sure which one of the segments is the one that actually needs to be, the bronchial segment needs to be taken. Fissure, again, in UK to have a nicely open fissure is not the common standard thing. So to do the tunnel technique is actually very common in my practice. So I don't try to dig into the fissure, I just lift it up and then find it an opening with the staplers. And that's again another way to minimize the air leak. In a kind of a schema way, if we want to look at that, apical segments are, as a technique, are very similar to what we do when we do upper lobes, artery, bronchus, and vein, and then the parenchyma. And of course, it's really important that we are assured that we are taking the stumps with us. Anterior segment, instead, we start with the horizontal fissure, and then we identify the vein, and then we take from the bronchus and the artery. So it's slightly different compared to what we regularly do, and it takes a tiny bit more time to learn to do an anterior segment compared to an apical segment. Posterior segment, I would say, is easier than the anterior segment. And again, if the fissure is not complete, we need to start somewhere. And then artery, bronchus can do from the fissure point of view. And sometimes I've done it as well from the top. But to be honest, of course, probably this is the most common way to do it. And basal segment, again, fissure, and then artery, bronchus, and vein, and parenchyma. Depending on which segment, the more anterior or posterior, definitely like that. The complex basal lateral, again, you can start from the vein, follow the vein, and then come up on that way. And then join it from the top, from the fissure for the artery. This is a CT scan of one of my patients, and just to show you, average age for our patients is about 75, normally a ex-heavy smoker, emphysema. COPD and all sorts. This, you've seen a nodule on the left-hand side, which is part solid, and that's basically part of the procedure. And again, open the fissure, started digging into around the artery. And in this case, I used the energy device. You see that these anthracotic kind of lymph nodes, really, really common. And they're not pathological, of course. These are not the ones that we are supposed to send for frozen section, so to say, according to the most recent publications. And then, again, when we do the segmentectomy, we try to dissect from the hilum, going much more peripheral compared to what we do compared to lobotomy. Here you can see I haven't edited the video. There is a hole in the bronchial segment, if you spotted it, and I made it with the energy device. And I just carried on with the procedure because that was actually the bronchial segment I was going to remove. So unfortunately, it did happen, but with a stapler, just removed it anyway, which wasn't a problem. And then that's a venous branch that are done with the energy device in this case. And then basically we carry on for the parenchyma and of course, the more the jaw of the stapler opens, the better it is sometimes, and you want to to be more comfortable going around with the stapler as you take the parenchyma. And going forward, here at the end there was a bit of this slightly opening on the fissure, so I repaired it a bit just to minimize the air leak that potentially was going to come out from that side. And again, talking about what we were mentioning earlier on, the more you try to fix the issue immediately, the better it is. You see the lung is expanding nicely, and there is no issue. Posterior basal segments. Again, there is not really a rule, but mainly perhaps in this order. And that's another video of CT scan, better quality of lungs, perhaps, in this one, compared to the other patient. And that's a nodule on the left lower lobe as well. And this is more solid, as you can see, compared to the other one. And basically similar dissection going around. And sometimes I use the sling to go around with the to the structures just to help a bit, and that's it. And again, at this level, the more you're going to remove all the lymph nodes around, the more you're going to be free to actually identify your segmental branches and then actually taking the right segmental structure that you need. As mentioned earlier on, you can do the vein from the inferior view, and then as well bringing up that segment in that way, and then joining with a top view, if you want to say, it gets easier at that point. It's something I think that is easier to explain in theater rather than with words. It doesn't make too much sense if you want, but if you see it and you do it with a colleague, then it will make sense. It will click in your brain. And yeah. So moving on a bit. The parenchyma. No. And the lung is responding nicely. So in summary, when we do a segmentectomy, we need to have a deeper level of knowledge compared to the lobectomies, and the section as well gets more distal from the hilum and gets more complex. So you might want to use more devices if you need it or if you have it, and finer instruments, and of course it's really important to identify the right venous drainage. That this is to avoid horrible complications, which is one of the most common things can happen if we take the wrong venous drainage. Then we have consolidation in the lung and really severe complication for the patient. And then a good expansion of the remaining segments. Sometimes some segments can look like if they are a bit kinked after we remove, let's say you remove a posterior segment in the upper, and the anterior segment can sort of bend a bit posteriorly, and the bronchus, we need to remember, is less strong than what it is on the lobe side. And it can kink a bit, and then that segment might not really respond nicely. So this is something that we need to look at, because this is one of the most common complications that we have sometimes after a segmentectomy, that we see on the X-ray that segment that we saved made that much effort, and actually is not really nicely expanded on the chest X-ray on the CT scan. But it's not because we haven't done the wrong anatomy resection, it's because sometimes there is an adjustment that happens that we need to sort of rebalance. Most of the time that resolves itself, but sometimes actually we need to, see, cases where you have to go back and do a completion lobectomy just because of that. That's even worse, of course, if we take the wrong venous drainage. Prolonged air leak, it is a recognized, let's say, postoperative complication. There is a higher risk, especially if we do more planes and we join the planes together. We know that, we don't really need to do a study about that. We know as experience, and especially if we have emphysematous patient. And then I mentioned the risk of congested segment, atelectasic, and the torsion, to be honest, personally, touching wood, I haven't seen it yet, but it's been documented. Some colleagues, they use like a stain suture, and I'm not really fond of that, especially if you have an emphysematous patient, but of course, everybody does whatever is more comfortable with. And I would say that there is a learning curve that needs to be done to reach competency on complex segmentectomies. It's estimated to be about 80 segments. And of course, learning online, attend to a course like this one, and fellowship. It's always something that I would strongly recommend. Thank you very much. Any question?
Do you use some type of marking for your nodule, or you just do 3D reconstruction on all your surgery?
So at the moment, we have the Lumicite platform. In terms of issues is, of course, timing. Definitely, If it's something super complex, you can use it, but it's an hour, let's say, of GA anyway, extra general anesthetic, and it's an extra, if you want, it is a case that is not happening. So if it's something that easily I can either palpate or I can identify easily from the CT scan which segment I need to take, I'll just go straight for that.
Always do
Anatomical segmentectomies.
sub-segmentectomy, or in some cases you just do wedge?
I mean, in my practice, I do wedge only for very old and frail patients. I wouldn't do a wedge on a 50 years old fit patient, not even for a metastatectomy. Where I am now, in terms of, I can do it, and I will do a more anatomical resection rather than just a wedge. But I'm not arguing against that. It's just that I think, it comes with experience if you want, and it comes with as well other factors, definitely, yeah.
That's important. For example, in my practice, most of the resections I've done are always infections, even though they might be seen malignant.
Yeah.
They'll be infections.
Yeah.
So sometimes do like anatomical is somewhat of an overkill or an infection.
Yeah.
But this is you only do cancer, you say?
Well, 80% of practice is cancer. We tend to have diagnosis before going to theater, 60% of the time, hopefully. And again, it might be either an EMB with a biopsy on a different day, so patients coming for, let's say, 2 procedures, or CT guided bio, the regular, basically standard practice. Frozen section, we try to limit a lot. That's because it takes a lot of time in our theater, and but yes, of course, if it's a very peripheral and something that you can wedge out easily and send for a frozen section, then absolutely, of course, I agree with you. What I don't like to do on the other side is to do a wedge resection on a patient where I'm going to do a segmentectomy, or even more for a complex segmentectomy, because I think that piece of specimen that then is left as a complex segmentectomy is like a jigsaw puzzle that the pathologist will never put back together, if you want, with the previous wedge. And because we are doing this, we were really keen on our margins, then it will not make sense for the cancer point of view. So again, it's a discussion that I have preoperatively with the patients. Sometimes, we do have this really open discussion. Okay, this nodule, we don't know what it is. It might be infective, it might be cancer. We think it's probably, early stage lung cancer, but, there might be a chance that it's tuberculosis or whatever else. There are these options. Oncologically, if it's cancer, I'd rather do this, but I'll do what you think, you want. Yeah. Firas.
Yeah, thank you, Robert. I have 2 questions actually. First one is, what are your indications to perform a 3D reconstruction before the surgery? Are you doing it for every patient or specific patients? And second question is, what you do when you have a nodule just in between 2 segments? Do you do bisegmentectomy? Do you do 1 segment and wedge, or do you do lobectomy?
Right, yeah. So first of all, we don't have a 3D reconstruction system in our hospital yet. It's coming soon, but so I'm still working with a CT reconstruction. Of course, the recommendation is that, especially for the complex segmentectomies, it's much easier to read the anatomy, it's much easier to read the structures, and then, of course, you plan your procedure in a nicer way. You don't have, you don't end up basically making mistakes. So that's the main recommendation, basically. And then, of course, the planes and everything. So it does help on that sense. as is 10 years I'm doing segmentectomies without that, I can tell you it can be done and safely, yeah, as you know, we know, but it's an extra tool. It's like, you know, it does help, and of course, I can't wait to start using it, because sometimes it's very difficult and you make decision intraoperatively that actually you should have made before with the right tools.
Sometimes you go to very simple,
Yeah.
like segment 1 or 6, and you find anomalies.
Yeah, exactly, you know, or exactly what you were saying. If the plane is, when you do the reconstruction, you see that if you take only one segment, the plane is going to be too close to one intersegmental, the nodule is going to be too close to one intersegmental plane. Then you can actually start planning, okay, sorry, I don't want to do this, I want to take the other segment next to it. So in this way, I have really good margins. That's one of the main things that, as well, the 3D reconstruction helps with. In that sense, again, if I can, normally I will do 2 segments, 3 segments, whatever is required. And then, of course, you know, sometimes we have to do lobectomy, because that's different, but, you know, it's do the segment plus a wedge. Again, depends. It's like a compromise kind of situation where you balancing your risk and benefit depending on the specific patient. If it's an elderly patient that you don't want to prolong the general anesthetic, and you take a segment 6, and maybe the margin is too close, let's stay a tiny bit more that way, it's fine. Nobody's going to argue with that, I think, you know, and I think it's still good practice. But of course, you know, if instead is a 50-year-old patient and you want to have really good margins, maybe you have to do 6 and plus whatever. And but then it's maybe, I don't know, depends on the level of experience, another hour in theater for the patient. So it's, you know, it's all, you know, as normal. We balance, you know, everything, and depending who's the patient and how fit is the patient and these kind of things. Yeah.
Do you have any standard practice for these things when you're doing your second therapy?
Yeah, I do the same as I will do for lobectomy. So I do the full lymphadenectomy. So it's I do the mediastinal dissection, and I do all the hilar dissection. And to be honest, I do more probably than a lobectomy, because then you do 12 and 13 that normally for a lobectomy I don't do, unless there is a specific reason. Yeah. So yeah. Okay. Thank you very much. Gracias.
Muchas gracias a la doctora, excelente charla, aprendimos mucho. Ahorita vamos a presentar al doctor Luis Hernández. El doctor es cirujano torácico, es especialista en Bats Uniportal, hizo un fellowship en Shanghái de Bats Uniportal, ahora trabaja en el Hospital Universitario de Coventry en UK y es experto en cirugía mínimamente invasiva, tanto en Bats como en robot. Mucho gusto, doctor.
¿Pueden prender la luz, por favor?
Son de madres.
Gracias. Hi, sorry. Thank you for the invitation to Dr. William Guido. Having witness of the beginning and planning of the CAMIT, and now it's a reality. We're in the 4th edition. Thank you for the invitation. We're going to talk about segmentectomies, tips and tricks, but I want to do this session more interactive. So I'm going to write some questions to the auditorium. You can reply. I will love you give me your input. So just to make you aware where I work in Coventry, it's in Midlands in England. We are a very large trauma center. Our hospital was the hospital that gave the first COVID vaccine in the world. So when you saw the TV, it was in my hospital. We are one of the units doing the pilot screening lung cancer in UK since 2020. So we have more than 2,000 scrutiny patients in Coventry. And we operate more than 350 patients already from the lung screening cancer with very good results. Around 2,000 beds. We are the only uniportal unit beds in Coventry, as I'm aware. And we do 98% of our practice by keyhole, all uniport. So we have only 2% rate conversion in lung cancer. That's what I mean with this 98%. Of course, we do open surgery, we do tracheas, we do chest walls. So how we do perform segmentectomy in Coventry? I'm going to give you my experience because I think it's very important for you, like young surgeons or surgeons trying to improve your skills to see different opinions. You saw Mahmoud, you saw Laura Sochi. So when you go for a segmentectomy, as you saw here in the previous talks, it's about localization. There's many ways to do it. 3D mapping, has navigation bronchoscopy, as Mahmoud does and is his current practice. For example, in China, they're still doing wires with using the breast cancer or just a hook wire. And the CT scan or 3D reconstruction. This is very important to mention because Diego was mentioning yesterday in Mexico that we should not allow the industry to drive our practice. What I'm meaning with this is the 3D reconstruction is not new, guys. It's because now the companies are pushing for softwares and for us to use it. This is a picture for 2014 using 3D reconstruction, okay? That's what I wanted to show you. This is in Shanghai Pulmonary Hospital. So 3D reconstruction is not new. It's a tool. It will help. I think it's very good for education, but I absolutely defeat the point that I have been doing segmentectomies. I did more than 1,700 uniportal VATS segmentectomies, complex and simples, with no single 3D reconstruction. I only missed 2 lesions because the scan was very old and the lesions disappeared, not because I missed it. So what I want to say with this is, what is our more strong tool as a surgeons that we don't use or we don't teach, or maybe our trainees are not getting enough knowledge? Anatomy. If our trainees really use the anatomy, you will find any lesion, because if you go to the scan in the en las tres posiciones, the 3 positions, you will go and reach and look for every subsegmental bronchus. You can even see if you have any anatomical variations. When you have an anatomical variation, or you have one single vein in the lower, in the left side doing a left lower lobectomy, and then you go to the scan, you always find this an anomaly. Tell me if I'm incorrect. So you find anomaly in your patient during the operation. You go back to look at on the scan, and you find it. So this means that we are doing lack of study and lack of anatomy in our patients. And I encourage my trainees to go and look for the anatomy in the scan. In all in the lateral position, you can go and see the subsegmental bronchus, and this is very important. Again, I'm not against 3D dimension. I think it's a very good tool, and I think I'm very happy to use it when it's free, not when I need to pay thousands of pounds to have a software in my hospital, which I strongly think is no needed if you are you know the anatomy. If you go and go the bronchus you are looking for, or if the lesion is in a segment, you take the segment by anatomy on the scan, and if you're able to transpolate this into the patient, you will find the nodule, you will not miss. Or even if it's in the middle, you do 2 segments by segment. If it's in between segment 6 and 10, you do segment 6 and 10 by segmentectomy, that's it. So I think this is what I encourage to my trainees, to study anatomy a lot, and we do this at national level with the National SCTS program of trainees, and it's very important. Some people do, for example, in Shanghai, they do a perioperative anatomy. I don't do it. What I encourage a lot my trainees and people who enjoy this trip is margins. If you realize we have many clinical trials, the Japanese, the American, but nobody talks about margins. They talk about rationality of margins, but nobody tells you, oh, all my patients had 3 or 4 centimeters. And I think that's the reason our paper years ago about wedges, which we satanized wedges many years ago, because they never tell about margins. Maybe they were doing 2 millimeters margin, and that's the reason the wedge is so bad. I strongly believe, and I have been talking with many surgeons around the world, doing more wedges with better margins. So, and we now prove that with pure granulars GGOs peripheral. You do a wedge, and the patient has 99% survival in 5 years. So our practice is changing. Hybrid theater, whoever has this tool is very good, and is what Javi was telling. We must drive this way because we don't need to let pneumologists to get this and do and happen to us what cardiac surgeons had with the cardiologists. Skills, you need to see where are you in your learning curve. You do 3 ports, 4 ports, 1 port, 2 ports, it doesn't matter. For me, the best is uniportal. I think now we have very good evidence. Even the Violet is telling that the uniportal has better results than multiportal. It's very important that you know how to move your hands, and I think there's many courses for that you should attend, or if you're already in that skill. Also, it's very important to speed your operation. I know maybe sometimes difficult, and even in LATAM, to open a harmonic or a ligature. But believe me, if you know how to, we do special courses in the UK to master the use of energy devices. With the energy device, you can cut, dissect, like open surgery. You remember in the open surgery when we were using the scissors to peel the bronchus, you can do the same with the harmonic. So if you master the use of the harmonic or the ligature, doesn't matter which tool, it will speed your operation. So in this operation, what I'm doing this video because I want to show you, I'm not exchanging instruments. I'm not using the snake. I'm not using nothing until I fully prepare the vein for a trisegmentectomy. And I'm doing this this is a speed video, of course, but I'm doing this in 3-4 minutes. So in 3-4 minutes, just with using energy device, whoever you like to master, you can prepare this. And so I'm dissecting and opening, and if every time you are avoiding to exchange instruments, imagine if you exchange instruments 20 times, 10 seconds, you already saved 200 seconds, 2,000 seconds. So at the end of your operation, you can perform a segmentectomy in 30-40 minutes, but maybe some people will say, oh, that's impossible, you are a ghost, you are a liar. No, it's possible, guys. Hair dissection, I think Laura mentioned this, it's very important to remove every lymph node you find during the segmentectomies. And this will open your planes between the vessels and the bronchus, which sometimes the bronchus in the segmentectomies is the most tricky part for me to pass. The arteries normally are very easy to dissect if there's no crazy lymph nodes or TV. You can master also if you cannot have energy devices because it's very expensive, there is another tools. For example, in Shanghai Primary Hospital, when I used to work there, every team mastered a different energy device. So you can also master the hook. The hook, I think, is like 20 pounds and is disposable. And you can deskeletonize very nice the arteries. In my practice, I mix and match every energy device because sometimes you cannot reach that level of precision with the harmonic. Sometimes you need the hook to get this and to get this skeletonization of the arteries. I don't encourage this, but with ligature and with the X1, we love to try technology in my hospital and to test it to the limit. I'm not encouraging this, and I know Diego doesn't do it, and he's against that, and many surgeons here. But we did a middle lobectomy just with energy devices, and it was all well. Of course, we went very peripheral to the vessels. If the devices are tested to do 7 millimeters, I strongly believe they do more. I don't go more than 5 millimeters to do a vessel with energy device. I know many of my colleagues don't do it. They prefer to sleep nice overnight, but we test the instruments, they work, and it can be done. We have no issues, and we start doing this already since 2020 with no single issues using only energy device for the vessels. I'm here to give you tricks. So this trick is when the fissure is incomplete. So if you see, we are doing a segment 6, that's the basal segments on the left upper lobe. And what I'm showing you with this video is, can we do the fissure with the energy device? Yes, we can. Can we avoid the air leak? Yes, we can, because we know it's better the stapling, no? If we need to open the fissure. But in this case, we are opening, we are dissecting. And what I want to show you is, we keep going, we find the artery. When you find the artery, basically your fissure is quite easy to develop, which has Laura explained. I also do fissureless technique, which it means is open the fissure, following the artery and pass the stapler. In this case, I was doing the fissure with the harmonic, and then my way to avoid the air leak is I'm taking part of the upper lobe. So the air leak is going with the specimen, and there's no air leak, and this again will save me time of exchanging staplers, exchanging cartridge, and then you, because in Coventry we have a lot of pressure. We need to develop 3 or 4 or 5 cases in one day, all lobectomies or segmentectomies, or three segmentectomies and 1 small case. So we cannot be wasting time. Intersegmental anatomy plane, but you can, as Laura explained, inflation, deflation. I use inflation with anesthetist. You can also do it, as Laura explained very well, with the transillumination. And you need to know there is a Japanese team that they do the opposite to inflation. They pass a catheter to the segmental bronchus they want to remove, and they inflate it. So again, you need a cool anesthetist, open, but you can choose which one is the best for you, no? The best, because some people say when you expand the lung, then it's very difficult to do the fissure. So if you do the opposite, you only inflate the one you want to remove, you can do a better fissure. I think everything is related to the experience of the surgeons. Intersegmental play, I'm going to skip this because I want to show you more videos than. So, Carlos, which segment you will do here? Which segment you will do here? Will you do a segment? Somebody else indifferent? Maria Jose? 3? Somebody else? So that's the way I teach my residents. For example, in the CT scan, I divide this in 4. So we know it's anterior, okay? We know it's more lateral, and sometimes in the scan, I count the ribs from up to down. So this is anterior, so you're right, of course, could be middle low, but in this case, it's an S3 segment, okay? What I want to show you here in the S3 segment is the different maneuvers that we do. I always mark the lesion. I always try to find the lesion. I think, of course, we will move forward as Mahmoud is doing. When we start doing robot, we cannot feel the nodules. So we will be marking. What I always do is start to find the lesion, and I always mark it with a stitch. Because when I put the energy device, it will be gone in 30, 40 minutes. When you are trying to do the fissure, delivering the fissure, you will not find it. So I always put stitch, and I always let my trainees to do the stitch. So they start developing these skills for this. So for the S3 segment, in the right side, you need to deliver, of course, you need to divide between S3 and the middle lobe. It's the most important. So you need to realize what are the veins. You need to go to the central vein and differentiate which one is for S1 and the one that's going for S2. And then to see how many veins you find for the S3. In this case, I found 3 veins for the S3. So it's an aberrant anatomy, but I don't like to say, to be honest, aberrant variation. I think that's the beauty of thoracic surgery. Every case is different. So we will find always different arteries and different bronchus, no? So I don't think it's anatomic variation. I think it's the nature of our thoracic surgery, always different cases. So here in the vein, I'm teaching you this because in the veins, you can really push a bit with the stapler. You do this in the artery, your artery will be completely broken in 2 seconds. But you see, you need to move your stapler and it will pass, and the vein will feed. As soon as you have in a good position, the vein will feed the stapler and it will slide. And you know there is nothing there, no? So then you need to deliver also the arteries from the hilar structures and dissect as many lymph nodes as possible. And the fissure you can deliver it with harmonic, or there's different techniques with the stapler, as Laura showed you. Oh, sorry guys. And this is maneuvers to pass the stapler, when you are rotating the stapler, but making sure that the pail of the stapler you are moving, because if you are moving only the handle, the stapler doesn't move adequate. So you always need to rotate, including the handle is very important. And I want to show you this because you may say, oh, he's putting the stapler and he's moving a lot. Believe me, it's very, very good movements and very restricted movements. So here is the artery. As soon as I put the stapler, look, it's in real time. I know the stapler cannot go because this is an artery. You cannot be doing these maneuvers. So you need to have a very nice pass of the artery. So just putting the stapler, I realized I cannot do it with stapler, so you need to master different skills. You can do it with energy device. In this case, I pass it with a silk tie, and I tie, because you see that it's an artery, and I think it's a bit more than 3 or 4 millimeters. So we will show you to tie and do these knots in the lab with the live animal, and how to give stitches is very important that you deliver this skill, because a stitch is not expensive. Everybody can do a stitch in every part of the world. And then to deliver the bronchus, for uniportal, I love the right angle, because sometimes like this, when you have the structure completely in front of you, if you try to dissect with Gonzalez Rivas or another instrument that is less than 90 degrees, it's very difficult. So if you have a 90 degrees, you can pass it, like in this case with the bronchus. I love to put silk ties. I don't remove them. I follow open surgery principles. We used to tie everything with silk, and we leave the silk there. So if I can remove it, I remove it, but if it's a very difficult movement, I don't do it. This is another important tip. Always pass your suction to the bronchus, or segmental or not, and it will give you the pass. It will create like a tent to pass your staplers. And then inflation, deflation. I'm gonna skip these ones, but it's different techniques if you have a partial fissure or if you have a small fissure. So in uniportal, the nice thing is we follow the open surgery principles. You can pass the fissure as we used to do in open surgery, okay? So I want to show you this S3 in the left side, how you can achieve a very nice deskeletization of the lesions. We did this, we performed this video for a manual, so I will do this nowadays with just energy device, to be honest. In this case, we put a clip because it was for a manual. I don't like metallic clips, but it was the only one I have at the moment. I have no polymeric clips. I don't like metallic, and then we use the harmonic. So this is the end of the dissection. Who wants to tell me which segment will be this one? Silvia?
It is malignant lobe. There's no indication for segment.
So I did a segment because it's less than 2 centimeters. It was 1.6 centimeters, and I was through the guidelines. So I did this.
You know, the guidelines are wrong. Actually, too.
Yeah. I mean, I guide my practice also depending how is the lung function. If the patient is 50 years old, if it's 60, you will see another case which maybe you will not agree, nobody of you, but I would like to show that case. It will be, of course, so in this case we did segment 8. What I want to show you in this case is it was no fissure at all, zero fissure. And what I want to show you here is you can persevere this segmentectomies, dissecting, and it looks very difficult. So I was just looking for the artery. You go in the aliar structures to see where is the artery and the vein, and I still opening the fissures until we'll see like open surgery. I go below, I see the origin of the artery and the veins, try to pass the fissure and doing a stapler fissureless technique. And then with patience and perseverance, we managed to open the fissure. I want to show you here to all the people who is embracing the trip of segments is after patience, this is what it happens when we open the fissure. The procedure becomes very easy. You can see now the artery, immediately the bronchus, and as soon as you do the bronchus, the vein is below. So that's the vein. So for a very difficult procedure with patient, we end up with a very easy segmentectomy. I will skip this, and I want to put this case. This is not me, this is my trainee. And I think it's very good to learn from the people who is learning. So this is the case I want to show you. This is a 86-year-old patient with heart ischemic disease, very high risk. Lung function is adequate. I think, I don't know, I would like even the opinion of the experts here, what they will do. The lesion is 4 centimeters 86-year-old patient, SUV of 6, and she has stents, and she is, of course, in anticoagulants. What you will do, Laura?
She mobile, she independent.
Yeah. Well, I don't believe S1 in 86 now, because as soon as the patient delivers any complication, you know they go downhill very quick. So what you want is, absolutely, should do a lobectomy by the guidelines, as Diego mentioned. Somebody will do a wedge.
Some logistic things, because we usually will take it out during the wedge, send it to frozen, and then act after frozen. So I don't know if you always decide before.
I think in this one,
But you don't have like a CICICA option. You don't have a pre-operating kind of biopsy. We have it available.
You don't use it.
No, we have it.
You
We have it.
You have it, but in this case, they didn't have pathology, right?
we didn't have pathology, but it looks highly suspicious of cancer. But when the one you think is cancer, then end up being a pneumonia, to be honest. So this is my own opinion. Yeah.
The discussion between this wedge or this lobectomy has to do a lot with the patient. She's 86.
86, exactly, that's my point.
Life expectancy, she's triple stents, double stents, triple stents, whatever. She's 86 years old.
And she only wants quality of life 3, 4, 5 more years.
I will do wedge resection, send it to pathology, see what the result is, see if I can put her some immunotherapy or whatever, and that's pretty much it.
Absolutely, that's what I'm asking, because I'm sure every people will do different things. Firas will do a lobectomy maybe, Laura will do a trisegment, maybe a wedge, and nobody can criticize nobody because it's 86. Many people in England will, 86, with triple coronary bypass. Exactly, you see where I'm coming from, that's...
This way you have therapy. If you're talking about
Absolutely, but we give patients choice. So the patient wants an operation, she aims for this to be removed, and she only is expecting to have 3, 4, 5 more years, leave me alone.
Maybe 10 years, I don't know. My mother died at 99. She was 86 and she had this and depending on the condition.
Exactly. But that's what
How is the condition of the patient? If she's really fit, okay, that's my patient is 86, but she looks like 70. And
no, I agree.
But if she's 86 and she looks like 99, so.
But if, for example, in England, you need to have the balance of a wedge or a lobectomy or a segment, because if the patient do very well, oh yeah, you did the correct decision. But if the patient end up in ITU, 3 weeks ventilation, 86, with the family asking what to do, and then we say, oh, why you did a lobectomy? Why you were so invasive? If you were, as you say, 86, why you didn't perform a wedge? So you need to be very careful, at least in England, with the decision you do and what you are expecting from the patient. So in this case, we talk to the patient. When I go inside with these patients, I try that they let me do, I expect the words, doctor, do your best and your decision during operation. That's what I try to guide my patients during the first consultation. So then I have the open decision to do what I can do in the operation. Yeah, Laura.
For this case, it's important to see the lung window, to see how it looks like the lesion. With this window, you don't know. Show me this is the lung window. I'll show the complete CT.
I think, is CICICA biopsy and functionally we do as well as CPET and an echocardiogram, all of these things, yeah.
But you did
Before you decide.
bronchoscopy and CT.
Everything, yeah, of course. We're in England. We don't leave any question into theater.
Everything was together. Everything was together.
Yeah.
Why would you do a wedge? Because it's more simple, or because?
Why we will do a wedge? I think I didn't do a wedge, but you can do a wedge, and I will not criticize you. And even Diego is saying he will do a wedge, possibly. He will. maybe thinking a wedge. That's what I'm asking this case to everybody, guys.
If you accept this patient to go to surgery and to anesthetize him, you have to give him the best option, the best operation. And I'm not sure that big wedge resection had less morbidity than proper lobectomy.
Yeah, but I'm gonna send you a very tricky question. So you do a full lobectomy, then you do a mass lobectomy, and you cut the stapler line, and you prepare the artery, the vein, and the bronchus. Your pathologist will not know you did a lobectomy. He will only tell you about margins.
Yeah, the wedge will be very difficult to have a good margin. You can see it's very difficult to have good margin. Make such a big wedge.
There's no where to connect my laptop. It's gonna turn off in 20 seconds. Thank you. Well, I just show this case for discussion and to show you why in thoracic it's many options, and I think none. I think lobectomy is not wrong if you are happy to take the risk of 86. I think a wedge is not a bad option because you decide not to take the risk, and if you get good margins, we know the patient will survive. But the patient will survive at least 4 years with a wedge. She's 86, 90 years.
So send her to SBRT.
SBRT has many complications, many more than surgery. And that was what Mahmoud says, and I witness of that because I work in a center in Exeter where the SBRT was very aggressive, and I saw fistulas, trachea broken open.
I think if you decided to go to surgery, you have to give an oncological proper surgery.
Exactly. So what I did, I'm going to tell you what I did. I can be criticized.
One last question. You did CT follow-up or you had no CT follow-up? Because this case, I mean, you make bronchoscopy, you make CT puncture, you make a lot of things. So you have, I'm sure, 3, 4, 5 weeks time gone. So what is CT in 4 or 5 weeks? What happened? Say the same or not?
going to show the case is malignant.
Yeah.
It's very easy. He will not show the case if it's good.
Well, I put this case just to bring controversy to the room. As you,
I will second or wedge.
exactly. So, but that's what I say.
It's also okay if the patient hates.
Absolutely, absolutely. So what I did, I tried to balance the decision. I went for a segmentectomy, aiming for margins. If I don't have good margins, sadly I will go to the lobectomy. So I did a segmentectomy. So then I want to show you this. This is a video. I let one of my trainees to step into the case because when they are skilled, I think you should let them. And I will run this video, and I think I will finish with this because I have many more videos, and I can be here 1 hour, as Laura knows. So this is but it's very good for the people that is embracing this or learning. So this is my let me show you here. Okay. So first, for every surgery, you need a proper lifting of the hylium. So you see, it's doing an incorrect lifting. So here, sometimes to speed the operation, I use these peanuts. I know some people don't like it, but when you do this and you speed the operation, so you see, if you do it, you need to do it from down to up, not down, up to down. And then he's showing like then he's operating, and then I'm next to him, and I'm correcting him now. So soccer is very good to do dissections, and you see the suction is helping him to pull the tissues and guide where you want to take your dissector. So the harmonic you can grasp, and what I do is I grasp and I activate the harmonic and I pull away. We call it the pulling maneuver. So then you are always away, running away from the vessels. Here is very important to have the correct instruments. We use Scanlan because in England are the only ones certified, but we really trust Scanlan instruments, and they are very good quality. So it's very important you have correct instruments. Don't embrace the trip, the journey of this without all the tools. Here, this is very important. For example, this is a trainee doing passing the artery. I want to show you here. So in here, so in Uniport, it confuses you because you need to go that way, which is like a 45 degrees. The train is going that way. So as soon as you get the direction very easy, this is me passing and showing him how he was doing like that. And then you pass the staplers, always passing the same direction, and you can, this stapler is rotating a bit. You see, so you rotate, you pass, and you reaccommodate. This is a small tricks that we like to show for you to speed and do a more secure operation. In this case, the bronchus is completely in front of us, so we're using a right angle. And then the trick of the suction, that it creates like a tent, so we can pass the stapler very easy. So this, also I use this trick to pull the lymph nodes up. I will finish in 1 minute. So to remove the lymph node, we were doing this in open surgery. You will pull the lymph nodes up. So I use the same trick in the bronchus. Because sometimes if you have a bronchus in your stapler line and it's in one, they will give you positive margins. So you need to be very careful with that. And I'm sure this happens to everybody. And then inflation, deflation, and prepare the fissure. Can I show 1 of 2 minutes or I'm done? Okay, so with this, thank you guys. Trisegment. Ah, yeah, trisegment, adenocarcinoma, and because you just tell me in the moment. So I have the specimen. I can show you if you want later. We have a 4 centimeters margin with the trisegmentectomy macroscopically from the. So I have it here. Sorry, at the end of the video. So I think we were very happy during the operation with 4 centimeters. I think everybody will be happy with 4 centimeters macroscopically. I will. So we leave the patient with trisegmentectomy. We did this operation like 6 months ago, so I will let you know in 1 year what's going on. But she was not early, she did very well, and she went home in day 3. That's what you are aiming in an 86-year-old high risk.
Okay, so we're going to the coffee break. Just a couple of announcements before. Today at 7 p.m. we have a dinner at Sheraton Hotel for all the participants and faculty, please to join. And the other thing is that the coffee break is in the first floor. Follow us because it's on the right, the last part of the floor, okay? And afterwards, we will do the last lectures, and then we go for lunch, and then we have to go to the dry lab. So keep close because it's far away from here, okay? Walking. Oh, and for sure, a special thanks because I always forget to say it, but this course will not be possible without Medtronic, AstraZeneca, and the help from the university and the CICICA department, okay?
Sí, fue el caso, mira, te fue. Sí, es por eso lo quería poner, porque estás correcto. Sí, claro. Por supuesto, porque si el tiempo era porque yo sé que no, pero por eso a mí se me muere esta y me la van a cuestionar. ¿Por qué no le hice y darle calidad de vida? Con los sólidos. No, no, si te creo, güey. Pero eso lo sabes tú. Y los consensos de la ISP, pues,
Something is shit. Totally wrong. Está totalmente equivocado.
pero esto fue el
En
banquete.
China se ríen de esto.
Lo que sabes que pasa, porque en Latinoamérica menospreciamos el chino.
No,
En China, pero es que yo los americanos, los americanos están aquí, no tienen ni puta idea. No tienen ni
o sea, tú
puta idea.
por lo que sabes ahora lo has hecho una genial, aunque sea 1.8 centímetros
Nadie.
solo un gran
Prohibido.
¿Cuándo sale
No,
eso?
hay un estudio de poco por ahí que va a cambiar que es lo que define el problema superior es el tamaño, el componente, microcapilar. ¿Por qué un solo de 1 centímetro?
Pues yo llevo diciendo
Tiene un
eso
componente agresivo y uno del 2. Claro, tú haces una bioquímica de 1 centímetro.
y yo ahora, pero lo mismo, tú en escuemos, yo nunca una semana de escuemos.
Está mal. Es terrible. Es que es terrible.
Yo voy diciendo eso en pláticas, pero el consenso es una mierda.
El fallo de la. Eso es
Exacto.
lo falsa que es. Tú te pones a ver la cantidad de segmentectomías que hay en el brazo americano y son güeyes.
Todo güeyes.
Hace una arteria o una
Pero
vena.
yo con otro día hablaba con el
Es
doctor.
vergonzoso.
Hablaba con
En
el
China, bueno, ahí hacemos el mayor número de segmentectomías del mundo con diferentes. Años luz.
Lo que voy es que, pues, son chinos, ellos son diferentes.
Pero ya no.
Tienen otras
Ya no.
Como una foto con
En cirugía de nuca, ya saben lo que es.
tu WhatsApp, en tu deseo, mostrarte una camisa para hacer mostaza y dar un punto.
Sí, ya la copiaron, no sé. La copiaron, no lo sé. Es ilícito.
Pueden hacer,
pero el copia lo que da.
pueden robarse.
Pero da igual, pero tiene un montón de cosas que les ven.
Sí, ahora aquí
Y es cada uno puede que
el problema
tiene
es
mil
que
cosas que están años luz, pero no adelantado. Ellos viven en el futuro, nosotros vivimos 10 años detrás.
Yo digo, mira, China es el futuro de Europa y el sueño de la
Tú
TAM.
pones al mejor cirujano americano, al mejor en Estados Unidos, en China, y no está en el top 10.
pero no es solo
Al mejor, el que quiera.
no es solo que te den, porque con eso da todas las pinzas ya. El costo de la pinza ajá, entonces digo, ¿cómo me explico? Porque yo trabajo en un hospital que hay dinero y yo trabajo en otro hospital donde no hay nada. ¿Ya? Entonces yo todas mis pinzas que tienen en ese hospital, yo las llevo, yo son mías. Entonces yo puedo comprar la cambia, ¿no? Entonces menos mal, y ahí lo uso. Y esas pinzas, a veces me suelen un poco mejor que tal vez un poquito más dura.
Y la grapadora es mejor. Tiene una grapadora que uso.
Por eso voy a ir en marzo.
Se les va cambiando el futuro. ¿Por qué? Porque lo que estamos haciendo es mandar el movimiento operatorio.
Y ver que
el
CTP,
patólogo
cadena,
y si hay un porcentaje mayor del 10% hay que hacerlo. Aunque sea un centímetro.
Pero yo solo llevo, o sea, yo no me considero un chingón, pero llevo diciendo años que va a ser dependiendo del tipo de histológico.
Hay una cantidad de
Y más luego, si lo hacen mal, va a ver que va a ser bien.
Yo en México, pero no me voy a retirar y estuve bien bueno, ¿no? Llevo 2 años, es que era agregado y ahora
Nada, era todo lo que hermanos. Todo, como si fuese para ti, la casa. Bueno, con la nueva,
Sí. ¿No puedo tomar café? No, yo tengo aquí café. No, allá hay. Allá hay. Sí, sí, no, tengo café. Y los aceptamos, y damos la orden. No es lo que yo quería, un aparato que me hagan. Yo lo quería era capturar el video de la presentación directo como un video y tener la cámara para entonces, hicimos poner una cámara que grabó todo. Pero sí estaba ahí. Sí, 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 eso es lo que siempre empezamos a hablar. Bueno, ya él está en la
Sí, puede ser, la cosa que siempre tenemos.
È un unico brasiliano che vince.
Y me dijeron, che, ¿qué es eso? Que nos ponemos a llegar.
Did you find your phone? Did you find your phone? How's the team over here? Did you play yesterday? Okay, perfect. Are we gonna be talking?
I will start.
Lecture or
Lecture, just to gain some time, I think.
It's only for VIP. Yeah, but the thing is, it's you who lose, not us.
Yo lo veo, ¿eh?
¿Mm?
Yo lo final.
Sí, todo al final.
¿A qué hora?
Como en unos 40 minutos. Si quieres darte una vuelta, hablar, hacer tus cosas ahorita.
Sí, no estoy por aquí. Vale, o sea que yo... ¿Ahora quién habla?
Yo, para sacar esto
Hablas
rápido.
tú y después.
Tiras y luego tú. Para ver si puedo ponerle candela a esto. ¿Dónde está el cable? Perdón. Okay, so we're going to continue to try. I'll go a little bit fast because we have to keep up with the schedule a little bit. And this is a very not too deep perspective of immunotherapy, mostly because I think it's a very good topic to discuss in terms of how you have been dealing with it, your experience after neoadjuvant immunotherapy, and what is your experience per se. So, just 1 second. Okay. So, as you know, lung cancer treatment is a multimodality approach. I think everywhere in the world right now is something that you all have, no? MDTs, and this is the way lung cancer is handled. Doesn't matter where you are. And it's a recommendation because adherence to guidelines is 90% of the time when you do presentations of the case through an MDT. When you do it by yourself, usually it's not the same thing. So this is why it's a strong recommendation to always discuss lung cancer patients in MDTs, just to get adhered to guidelines. But what happened? Guidelines are actually that, just to guide you a little bit on what to do with the treatment of the patients. But as you all know, there is no recipe for every case. There's no ring that will rule them all, okay? Each case has its particularities, its special things that you always have to consider. And there's when experience and your local abilities, your local institution plays a big role in order to do what you have to do. So, before, you will just read the NCCN guidelines and you just put the patient through a path and you know what to do every time, okay? Right now, we are changing that paradigm. We're trying to do precision thoracic surgery. That means that each case, you follow the treatment that is better for that patient. We don't have no more cancers, we don't have more diseases, we have cases, we have patients, and that according to that is what we're going to do in the treatment that is most recommended for that, okay? So options, we have a lot, okay? We have surgery, we have chemotherapy, ablation, radiation, immunotherapy, and target therapy. Which one of those, it depends mostly on what type of lung cancer, what type of patient we have. And since 2023, things have been changing a lot because it has been a landmark for the treatment of early stage non-small cell lung cancer. Why? Because a lot of things have been changing. Immunotherapy is a big thing that has proved results that not another systemic treatment has proved before. And also the fact that screening programs are being approved around the world have allow us thoracic surgeons to now change the way we get our cancer patients. Before, the screening, usually our patients were in advanced cases, metastatic cases, or borderline resectable. Right now, it's supposed that with studies of screening lung cancer, about 65% of all patients that we are diagnosing right now will be resectable patients. So the majority of patients will need a thoracic surgeon to be there to handle the things and decide what to do. So what we're going to talk about in this lecture is basic of immunotherapy, just to give a little bit of background. The management of non-small cell lung cancer in the era of immunotherapy. The main study that support this, the perioperative immunotherapy, and how does it affect our surgical resection mostly, okay? So, the basics is practically this. I always say that we should not be so egocentric to think that we will know more than millions of years of evolution. And I think this is one of the reasons that immunotherapy is doing so well, because basically what it does, gives the immunologic system of us the chance to fight against cancer just by avoiding cancer signals that usually make them unable to respond. So there are two things. Basically, the tumor cell has receptors that are PD-L1, and the T cell has a receptor that is PD-1. Okay, basically, when the tumor gets in touch with these receptors, they put the T cell in a sleeping way. Okay, so what else does the immunotherapy does? Basically block this signal through the PD-L1 way. So there's no connection now, and then the T cell is not inactivated, and then it can respond to the tumor cell. So just by doing this, you give your immune system the chance to fight back, okay? So immunotherapy, in a nutshell, is basically this, giving your immune system the way to fight back against the tumor, just by blocking the signals that usually they this. This is a thing that was very important in 2018, because after, of course, it has more than just 5 years of diagnosis, but since 2018, they gave the Nobel Prize to the group that basically find out how these immune signals worked. And it has revolutionized the treatment not only on lung cancer, but of course in melanoma, in breast cancer, and everything. So as I told you before, basically what it's doing is just giving the T cell the way to secrete and attack the tumor cells, and then control the disease. What are the considerations to think about immunotherapy? Basically, right now, in non-small cell lung cancer, when you don't have a driver mutation, that means EGFR or ALK, you have the chance to treat these patients with immunotherapy, and they usually have a better response than with all schemes of chemotherapy. Right now, all patients that have diagnosis of lung cancer should be screened and should be tested for every driver mutation and every receptor to possibly design which treatment will be better for him. Okay, so as you can see, there are a lot of ways, a lot of issues right now, and a lot of things that can be detrimental when you give the treatment that is not indicated. Okay. So everything started, usually how does research goes in the treatment of lung cancer? It starts with metastatic disease, goes through advanced disease, and eventually, if results are getting better and better, then they go through resectable disease. The first study that that did very good results with the treatment of immunotherapy was durvalumab, and the Pacific study was in 2017. And basically, this was indication for lung cancer that was not resectable. And the treatment, when you compare both results in terms of overall survival, you can put a finger between those two curves, okay? They defend a lot of results that usually with chemotherapy alone, you were looking for 5% of better results just with chemotherapy. Immunotherapy right now we're having enhanced 20 to 30% overall survival until 2, 3, and 5 years. And this was the first study that revolutionized the treatment in lung cancer and was given a start to these kind of issues, okay? So what are the approaches right now? You have neoadjuvant, surgery, and adjuvant, and each one of these schemes have a study behind it that supports the treatment in this case. Adjuvant approaches of lung cancer are basically surgery first and mandatory chemo afterwards and immuno. None of the adjuvant treatment with immunotherapy is concomitant, okay? You are scheduled before, you have to receive first chemotherapy and then you have to receive immunotherapy. Difference than neoadjuvant, who when you start, you both have combination treatment, chemotherapy and immunotherapy, then surgery, and then afterwards, depending on the study, immunotherapy. So, what to the audience, how many of you have done surgery in post-neoadjuvant immunotherapy. How has it been your experience in terms of difficulty, technical difficulties?
What the decision? What is the decision?
Every case, or how about you?
It's okay. I mean, it can be thicker on the iron, but better than the conventional chemotherapy.
Better than chemotherapy. Okay. And you were saying?
And also, we have with Dr. Miguel, post-chemotherapy and post-radiotherapy. And we have a vascular lesion injury because it was like so hard to approach.
And I think the early experience we had, we don't have too many cases. We have about 10 cases, I think, at all. But the early experience we had was like a coin toss. Sometimes you get to the case and it was completely stuck. The lymphadenopathies were like a paste around the artery that was very difficult to find a good plane or a safe plane to differentiate. And other times you weren't there and just was like any other case. So I think probably there should be some things. I don't know if it's the time period or something like that. Sadly, Diego is not here because I think he has a lot of experience because in China, right now, most of the cases are receiving neoadjuvant immunotherapy. So I think there's something we're not catching yet in terms of which patients are doing such a strong inflammatory response that makes the dissection after surgery more difficult. But at the end, if you talk with any medical oncologist, they all want neoadjuvant treatment. This is the best thing for them, and they think this is the better way to treat patients when they are able to do it. What are the pros? Well, the pros, sorry. Basically, it says that it can reduce the tumor burden. It makes a big tumor that is near the hilum more resectable, diminishes the time, have a downstaging. I think the most important thing about any systemic therapy that, according to the surgery, is that control micrometastasis, because you're only doing surgery to the things you're seeing, but you don't know if this tumor is already far away from your resection margin, even though it's negative, because the distant metastases are not able to control by surgery. And this is the way you can control and do a surgery more effective, I think. Also, it will show you how much this tumor will respond to this treatment, because you will operate in this patient 80% of the times, and you will send this patient to the specimen to the pathologist, and then he will say, okay, it has complete response, or the tumor is still the same, it's still active. So you will know how this patient will respond to an adjuvant treatment also. And the other thing that every oncologist usually tells is you need the tumor to elicit a response. You need a lot of tissue to elicit a response, because remember that immunotherapy works by just letting your immune system attack them. So in order to make a bigger response, you need a lot of tumor there, so the patient can recognize a lot of the antigens and then mount the response and treat and do the attacking the tumor. When you do surgery and you take out this tumor, then the micrometastasis that could be, or the residual tumor that will be much less. So the response for this antigen response will be also diminished. So the thing that you're wanting to do will be diminished by just doing this treatment after cutting the tumor. So usually the argument of doing neoadjuvant treatment is keeping the mass, keeping the tumor there to elicit a major response that will be helpful in controlling the disease afterwards. This is theoretical. It has been proved in mice. It had also been proved a little bit in melanoma, but in lung cancer, not yet. But this is a very strong theoretical argument for this, okay? What is the cons? And I think every surgeon, usually when you have a borderline resectable patient, usually worried that you have this chance to do the surgery, and if you don't treat it right now, you leave it for more time, probably you will turn a patient that is resectable into not resectable just by giving a little bit more time. So you are always worried about disease progression. Also, the side effects that are something that we have to keep in mind, because as time goes, immunotherapy is already being given in much earlier and earlier stages. And sometimes patients with a very small tumor that will be resectable with a small conventional lobectomy will go first to immunotherapy, develop pneumonitis, and then probably you will have a less armamentarium treatment to deal with this tumor. There is the worry of increased surgical complexity and delay in surgery. But what does the evidence says in this in these things? Well, two big studies. I will not go inside deep into the studies because I just want to talk a little bit about the generality of these things. But the Checkmate 816, that was one of the studies that proved and allowed to be approved by FDA treatment of neoadjuvant chemotherapy, so that 82% of the patients were able to go to surgery versus 75% if you do only neoadjuvant chemotherapy. So what does this say? This says that immunotherapy will allow you to more patients to get to surgery, but you don't compare immunotherapy to no treatment. This only tells you that immunotherapy is better to chemotherapy in neoadjuvant sites in the patients that are going to be able to get to surgery, but doesn't compare to adjuvant treatment. So it's better, you have to keep in mind this, okay?
70% didn't reach the surgery.
Yes, that is also the other thing. That when you compare it to nothing, to no treatment, then probably this is an issue you have to also keep in mind. And also, we'll discuss a little bit later. There are also some evidence on what happens when you don't do nothing in treatment just by letting time go. And just by doing immunotherapy, 20% more patients were able to get a lobectomy, and 30% less patients were able to get to pneumonectomy compared to neoadjuvant chemotherapy, okay? This is a comparison only to chemotherapy and immunotherapy, okay? The Nadim study that was done by the Spanish group, actually 93% were able to complete and undergo surgery, and they didn't have no intraoperative death or hospital mortality. As you can see on the side of the Checkmate 816 study, eventually 83 to 85% were able to go to surgery. Of stage 3A, 83% were able to finish and complete surgery, and in stage 1B to 2, 85%. And you compare this to chemotherapy, then you see an advantage of just using immunotherapy. But as I tell you, and there's no study that compares this, you have to compare it to no treatment or to adjuvant treatment in this kind of patients, because this is the evidence that it can be a little bit confusing in this sense, okay? We always worry, as I tell you, of adverse effects of the immunotherapy, hypothyroidism, pneumonitis, and supposedly, the evidence says in this study that basically 1 to 2% of patients are the only ones to develop an adverse event that will render surgically impossible to get surgery or delay the surgery so much that the disease will progress, okay? What happens when treatment is delayed because of just the patient waiting in a waiting list because you're in a public system, for example? I don't know, probably, I guess the majority of you don't have a big waiting list. You probably have patients that you detect them and you do surgery in a fact of whenever you can schedule in at least in a month. But for us, sometimes getting the patient inside the hospital, just admitting it can be an issue, and we can have more than 1 month or 2 months of waiting list in these kind of patients. So in stage 1 to 2, a 90-day delay did not affect overall survival, just for the patient when you have at a stage 1 and 2 in terms of waiting, okay? In stage 3A, there was a decrease in overall survival after 6 weeks of delay management or delay surgery or treatment, okay? And as a rule of thumb, usually 8 weeks or more, increase of staging, 30-day mortality, and decreased survival. So we usually repeat the CT after 8 weeks. Now we know where we take that, where we get that information. And in early stages, usually a 98 days don't affect overall survival. So it seems a little bit far-fetched to wait so much time to treat a patient with cancer, but sometimes during COVID, during waiting lists, these kind of things can happen. These all results are in clinical trials, but how about results outside of them, just by treating patients in centers and without studies? Basically, when surgeons deal with these kind of patients, there's no more bleeding, no more prolonged surgery, and no more conversion rate. That at least in our experience, we did have to convert, I think, a couple of patients just because we're not able to have a safe plane between the artery and the lymph node. And I usually think we convert when we have to see better, because I think you will not be able to see better than with a high definition lens 1 centimeter away from the artery. We convert when we need to put our hands inside and try to find the plane just by touching the tissue. So that was what we have. Adjuvant arguments, I think the most important thing is how easy it is for you to take to a patient and say, you have a lung cancer. Now you will have to wait for surgery after we do some studies and give you some treatment for 3 months or 5 months or something like that. It's very difficult to a patient to agree to this. Of course, you can do it, you can explain it and everything, but it's usually an anxiety thing that is always there. You avoid the side effects because sometimes pneumonitis with immunotherapy can prolong the surgery and make a patient non-operable. And the only curative treatment that we have found so far, you're not doing it right away when you have a resectable patient. So also, this is an argument to do adjuvant treatment, okay? So the thing is that the results with immunotherapy have a real impact. They have demonstrated a lot of good results in terms of overall survival that no other treatment has showed yet. So before the use of immunotherapy, you were looking at overall survival benefit of 5 to 6% with chemotherapy. Right now, you don't have yet overall survival evidence because the studies are very recent. But if you just compare the disease-free survival between these studies, you have 98% versus 85% in the ADORA study, and 65% to 48% of these kind of patients, okay? So at the end, immunotherapy has proved a lot of benefit in terms of disease control, disease response, major pathology response, and this is the thing that we cannot give away. So which approach can you choose? Or what would you choose when you deal with a patient? I ask you this, if I have a stage 2B, T2N1 patient, would you do neoadjuvant or would you do adjuvant treatment? Or which one will you prefer? Depends on your institution, I guess. Or to be a little bit more, I guess, difficult to choose, T2 and 0 patient.
I go to upfront setting.
How would you, Batman?
T2 and 0.
And 0. T2 and 0 patient, would you do adjuvant, neoadjuvant?
I think the neoadjuvant is still not, for these stages, still not evaluated. I think I will go with that.
And if it's N1?
N1, we can discuss it. I think you could think about neoadjuvant.
You go neoadjuvant? Okay. Is anyone doing neoadjuvant with N1?
Yeah, maybe.
Yeah, it needs to be biopsy proven in one.
Yeah, exactly.
And it needs to be chemoimmunotherapy.
And one with diagnosis 3.
Yeah. No. Proof N1.
Absolutely.
Neoadjuvant. Okay. At the end, I think guidelines are more or less what you're saying, but I think you will have to take in account where you are, the age of the patient, the comorbidities, and the ability you have to give this treatment in a sooner or later fashion. I think you have to answer some of these questions in order to decide which approach you will take. The biological rationale that we already discussed, I think that you need tumor burden in order to control micrometastasis, to elicit a major response in order to control the therapy afterwards. The pathology complete response, and if you If you see the studies right now, what they're telling you is the tumors usually between 30 to 40% have a major pathologic response with just immunotherapy. And you have to believe that this is a surrogate to overall survival. If this is the case, then probably these patients will benefit of neoadjuvant treatment even though they have negative lymph nodes, because just by giving this treatment, the patient will have a better possibility to control mucometastasis. Adjuvant treatment can guide your adjuvant, because then you will know if the patient will respond better or not to chemo or immuno. And if you have an overall survival that is the same in neoadjuvant and adjuvant in resectable non-small cell lung cancer. And as of now, it's kind of the case, okay? Although major studies are supporting neoadjuvant, a big difference that compare between those overall survival is not yet available, okay? At the end, when surgeons, what we think is possible is that probably some cases will be more difficult, but we have to know that this is our new reality. We are going to deal with immunotherapy right now. This is not going away. It's going to grow and grow and grow even more, and it's going to go to earlier and earlier stages as results start to be published. So we have to be able to know that this is going to be our reality, these are going to be our cases. And now, as every new thing, perhaps the beginning will be a little bit difficult, but at the end you will develop just things that are able for you to help and convert and finish these cases without conversion. Right now, there's between a conversion rate that is higher a little bit. And this recommendation is actually from the Society of Thoracic Expert Consensus, a consensus that was just published in September of this year. And there are a lot of recommendations, but I just summarize the things that are more important, I guess. And they are recommending, for example, for T2V, T3, and 0 neoadjuvant treatment. They give a recommendation for tumors, especially between 5 to 7 centimeters, and conditional recommendation between tumors to 4 to 5 centimeters. If they have N1, they all recommend neoadjuvant treatment. And of course, then N2 cases that are where immunotherapy has the biggest evidence, they recommended neoadjuvant and after surgery. And even they recommended in doing surgery in patients with N2 single station that are bulky, that do not progress during the treatment, and that you're able to do a lobectomy to cure these patients. So in these patients, they do a recommendation to do neoadjuvant treatment. And to multi-station, they recommended, of course, chemo, radio, and even immunotherapy, and surgery only if you're able to do a lobectomy to cure the patient. If you're not able to do a lobectomy, you have to do something more than that, then the recommendation is to go to chemo and radio definitive treatment. And also something very important, because I don't know if, for example, as 3 years ago, I remember that if you do chemotherapy and adjuvant treatment and you re-stage the patient and the patient still has N2 positive, then you don't do surgery in this patient. Right now, the recommendation is that if you have a patient that has persistent N2 but do not progress in terms of the disease, surgery is still recommended if you're able to do also a lobectomy. And then this other international consensus of immunotherapy for early stage, basically they all recommend perioperative chemo and immunotreatment for patients with resectable stage 2 to 3A. And I think the most important one is that immunotherapy with chemotherapy as induction therapy may be considered for selected cases of unresectable locally advanced non-small cell lung cancer. That is something that is appearing right now. And then I think you, as a surgeons, probably in big institutions, have to be dealing right now that some of your patients that you initially sent to receive immuno and chemotherapy, thinking that it will be a patient that will go to systemic therapy afterwards, then has such a regression of the lesion that it can become surgical. So they recommend going for surgery in these patients right now. Of course, it's a part of a trial, but it's a recommendation that is getting a little bit of push. And in this kind of thing, there are studies already that have proof that patients that have residual disease and you have an encouraging downstaging, then even though surgery may be technically difficult because of fibrosis and everything, you still have to treat and think that as a surgical candidate afterwards. And just as ideas to carry away, I think surgery post-immuno will be the everyday thing for us probably from now on. Whether neoadjuvant or adjuvant depends mainly in every case. It's not a recipe. I think that this is MDT's war for. I think the debate between neoadjuvant and adjuvant will finish because probably patients will receive neoadjuvant and adjuvant sooner than later, and that will be the progress in things. And at the end, what these studies have demonstrated is that you have disease control and you have better results in pathologic response and overall survival. So if it's a little bit more challenging, we will have to deal with it because things the end point is to improve the survival of these patients. And at the end, you have to take a choice for every case. So that's it. I don't know if you have any questions. No? Perfect.
Has there been any documented evidence on whether you do nivolumab or pembro in the feasible of its resectability?
In the what?
In the resectability, if it's feasible, does it matter whether which immunotherapy you use?
No. Basically, the results are independent of the immunotherapy you use. Because at the end, it's just, they just act in a different way. There's one blocks PD-1 and the other one blocks PD-L1, but the result is the same, yeah. No?
In my experience, when we are at the tumor board, let's say before starting the treatment, there is a big mass and you think, okay, he's going to go for immunotherapy and then do the surgery. And at the beginning, you're planning, I don't know, lobectomy, let's say. And then after immunotherapy, the tumor is actually responding so well that there is almost nothing left. And the tumor board is asking you, sometimes it does happen, and still doing lobectomy. So far, there is no evidence that we should change the initial surgical plan, but maybe that will change in the future, I don't know. But I've seen few cases with complete response with basically nothing, zero viable tumor left in the specimen. So we end up doing a lobectomy, and actually there is nothing alive there, which is really good, of course.
Have you seen a case with no tumor left, with no evidence of the tumor, of no mass, of no lesion at all? Yeah. So in rectal surgery, they have been dealing with this in response to chemo-radio. I don't think immunotherapy was there yet. And there was a debate that is still going on, and I think in thoracic surgery will also be still going on, that just don't do nothing. Just watch them and control the patients. I think it's difficult to do that because I think what immunotherapy gives you is a window to treat a patient with no active disease. And if you don't do nothing, probably just in a matter of years where the lung cancer origin, then we'll have in that place or in another place another tumor probably.
Even a normal start and develop carcinoma.
Yeah.
It's normal to.
Yeah, but it's a question, like, okay, yeah, it was an immunectomy, now I'm sure it just was the. And that's, debatable. If you really want to do an immunectomy after and not having really tumor, viable tumor.
To use the beginning of the disease as a marker of surgery or the disease you have right now to decide what kind of surgery you do. What do you do? What would you do? I guess if you have a patient that was for a sleeve before probably, and now it's for a lobectomy, would you do a sleeve or would you do a lobectomy?
I think at the moment we don't have evidence.
Nobody.
At some point we will reach some kind of evidence where actually maybe we can downstage the surgical plan a bit.
Because that could be the same for segment or lobe.
Yeah. Exactly.
So you have the mass and then it becomes once it
Yeah, why don't you do a segment now?
now?
But that's that's at the moment.
You keep the original plan.
We don't have
Keep the
anything
original plan, in my opinion.
actually guide
If
us.
the original plan was the molecule,
Yeah.
maybe not.
And they will have, but I think nobody, because in China you have a lot of immunotherapy cases afterwards, no? What do you think about in technical difficulty? Is just a chance thing or what?
It depends. previous affection. If they have lymph nodes and react, it is challenging. If there were no lymph nodes around the dissection, it was like an two, not much difference. A little bit more than that. The difference is when you do a peptide therapy. I operate a lot of patients after 1, 2, or 3 years with target therapy, and that is crazy. That is the
3 years after target therapy. Okay. So, no more questions, I guess? So our next presenter is Dr. Firas Abu Akar. He is a surgeon from Israel and Palestine, and he's going to talk about staplerless long resections. I think it's a very important topic, a very interesting topic, because we are very, very, very spoiled, and we all have staplers, and we do surgery with staplers. And what happened when World War III starts between Ukraine, Russia, and China, and Taiwan? We want to have staplers, and we have to know what to do. Okay.
Well, thank you, William, again, for inviting me again. Thank you, Miguel, as well, for this fantastic meeting. It's my 4th participation, I think, and I enjoy it every moment, every time. Well, first of all, I would like to take a moment to thank people who really influenced a lot my career and make me a good surgeon. So there is no doubt in this day, I think, that we have a huge benefit from minimally invasive surgery. It doesn't matter, robotic, VATS, multiportal, uniportal. Whenever you can do it by minimally invasive, it should be done by minimally invasive, I think. And I think this debate is already finished in this day. Uniportal surgery was started about 20 years ago, more or less, and now it became I think, the standard approach in many places. So we can describe the evolution of thoracic surgery by its stages. Like pre-90s, it was almost all the surgeries were done by open thoracotomy, large incision, non-muscle sparing usually. It was a very painful, traumatic incision, and people stayed a lot of days in ICU and long hospital stay with a lot of complications. Multiportal surgery was established at the beginning of 90s. First anatomical lobectomy was done by Roviero in Italy, and then it became more popular because its advantages, like it's more cosmetic, less pain, less complications, and so on. But even at that time, a lot of limitations was in this approach. People did not adopt the multiportal VATS everywhere. There were a lot of debates about the oncological benefit of this VATS lobectomy, and the same debate that we are talking now, it was at the 90s about VATS versus thoracotomy, but I think nowadays papers and research prove that minimal invasive is better. Uniportal VATS was established at the beginning of the century. Simple operation was done by Gaetano Rucco and these people. Then the first anatomical resection was done by Gonzalez, and this technique spread around the world. So stapler is a good tool for everybody of us, and there is no doubt that it can make the surgery easier, even in open thoracotomy. It saves a lot of time of surgery. Instead of suturing the tissue, you just put this stapler that can do the job. It may reduce complications, and there were a lot of papers that describe that stapler is decreasing the air leaks and give better outcomes. And maybe if we didn't have staplers available, we couldn't do a BATS, because BATS is very challenging surgery and need a lot of practice to get the learning curve. So imagine BATS without staplers. Maybe it wouldn't exist without staplers, or maybe it will be very limited for just for some talented surgeons. Well, I will talk a little bit about the history of the staplers. Dr. Holt, he's a Hungarian surgeon. He invented the staplers more than 120 years ago. This is the first, probably the first stapler was invented by this guy in 1908. It was about 5 kilograms weight stapler. Then after 20 years, almost 20 years, he developed another maybe more sophisticated stapler with less weight. This device was doing 2 rows at each side of staples. It was done by, the staples was made by steel, and a couple of years later came this guy, Aladar Pitts. He was the student of the previous guy, and he invented more successful stapler with a 2-line stapler, and he used silver clips instead of steel wires. And this stapler was the first maybe prototype for the future disposable staplers, especially in the abdominal surgeries. It was more lighter, 1 kilogram, and it was adopted by a company named Escolab, and it was very, very popular around the world. The disadvantage of this stapler, it was one use. You cannot use it more than one fire per surgery. So sterilization, it takes more than 2 hours for every time you use it. A couple of years later, this guy came with this, what we know now like a TA stapler. It came about 90 years ago by Frederick, and this stapler is thought to be the stapler what was used in the Soviet Union later. Then these 2 guys, Mark Ravitch and Dr. Brown, was American surgeons who were sent in 1958 to the Soviet Union after the Cold War as a good-willing peace mission, just to learn from the Soviet Union about their system of blood banking. And when they arrived to Russia, nobody showed them about the blood banking. They were offered to go and see some thoracic surgery as the thoracic surgeons. Then they met this guy, Nikolai Amosov. He was using this stapler in the Soviet Union, when at that time there were no stapler in the United States of Europe or Europe. So Nikolai showed these 2 surgeons a film about his surgeries. They tried to convince him to buy or to have a copy from this film, but he refused. Then Mark Ravitch tried many times to approach even the government to have these staplers, but all his requests were refused. Then with dinner, normal dinner, by chance, Mark Ravitch met a medical student in a restaurant, and this student told him about the stapler, that there is a military base in Leningrad who are manufacturing these staplers. So Mark Ravitch went to this military factory and bought as much as staplers that he can. Then he back to USA, started to do these experimentals on dogs, then on human beings. Then staplers started to be very popular in the world, and he developed his own staplers until we reach these days with many kinds and types of sophisticated staplers that we are seeing and practicing every day. This was probably the first publication by that Russian guy who published more than 2,700 cases of stapler using with very good results. So this established the feasibility, safety, and advantages of stapler. This study is a meta-analysis about maybe 8 or 9 years ago that compared manual closure of the stamp versus stapling. And they found very interesting results that there is no significant difference between manual and stapling a closure. But they also found that it depends a lot about the skills of the surgeons. So about safety. Okay. Many papers talked about the safety of the staplers, but let's see some real world. This is a wedge resection, okay? Big wedge resection for unknown pathology. It could be tumor or infectious. This is from my own practice, and you can see here, after the third stapling, the stapler was stuck, just couldn't open. It took me about 20 minutes to try to open this. I broke it, I even broke the gun of the stapler, nothing helped. So what to do here? So I tried with the energy devices, with the diathermy. At the end, I could find an angle to put another stapler from below the original one, then to continue the edge. In this case, the patient were okay, nothing happened, nothing dramatic happened, but can you imagine if this stapler was on the main pulmonary artery in pneumonectomy, for example, you are in trouble. So, yeah, so stapler is supposed to be super safe, but it's not perfect. This is a pediatric patient, okay? This is a case of 8 years old with a pneumothorax, which is not very common at that age. He came for a blebectomy. And you see here that the stapler was failed. All the stapler line was broken. Yes, in pediatrics, we usually use vascular stapler for the parenchyma. Okay, so another case. This is a left upper lobectomy in 85 years old patient for a lung cancer. Okay, dissecting the truncus anterior. Everything was smooth, no problems. Very fragile patient, very fragile tissue. until you put the stapler on the truncus anterior, and this happened. Okay? So, it's supposed to be safe. But if this thing happened, it could be happen with anyone. It could be happen with a second-year resident, and the patient could die of lack of experience. Okay, so what I did in this case, I just put a compression with a sponge stick after 5-10 minutes, compress and compress and compress. After 30 minutes of compression, this is what we had. Very interesting. Look at this. I mean, the bleeding stopped, but you can see here that the stapler worked at this area, but here something happened. I mean, this edge should be here, and all of this is a hematoma and edema. So what would you do in this case, Luis? Any other opinions? Stitch it. Okay. Glue? Okay.
If you went so far of 30 minutes to doing that, that wasn't the result you were expecting, and I will leave it like that.
You want, so again?
If you went 30 minutes from compression, that was the result you were hoping for. So I will leave it as you wish, because that was your aim.
Okay, this was the, I mean, at the beginning of the surgery, like, I mean, in the first branches of the artery. And the patient was 86 years old, 86. And it was a quite central tumor. Okay, so I decided to leave it, sorry. I decided. So let's watch it again, no problem. I can't stop. I can't stop.
On the same side where you got hematoma, there is already hematoma.
You mean on the branch? Yeah, maybe. Yeah, maybe. Yeah, I agree with you. But the bleeding started after the stapling. There were no bleeding before.
I think you should, it was a lot of tension before you fired the stapler. You didn't bring the lung.
Whatever the reason, we are not discussing the reason now. I have many theories about this case, okay? Many theories. I blamed myself, I blamed the resident, I blamed God, everybody, okay? It doesn't matter, this is not the story. What you do?
Leave him alone.
Okay.
You have to complete the rest.
Yeah, this is what I decided to do. I left this thing alone. Meanwhile, I was a little bit tachycardic during the surgery. Me, not the patient. Huh? No, I mean, I was tachycardic. The patient was okay. And we continued to do the lobectomy. I went to the fissure. I decided to leave this area alone a little bit. We continue. I just tried not to touch this main artery as much as possible. You mentioned here suture. I felt at that moment if I put a needle there, I will tear up the artery. That was my feeling. Maybe I had to do it, but I didn't. Yeah. So we finished here the lobectomy. You can see. So I decided don't fucking touch, exactly. Just don't touch. I put this Tacosil, BioGlue, all the goodies that I have, and I ran away from the surgery. Okay, you put this, also this, BioGlue, everything. Okay.
American video.
No. It's my video. It's my own video. Yeah. I will repeat that the beginning of the surgery. The patient went home 3 days after, and we did a CT scan after the surgery. Everything, the artery is okay. I will repeat the surgery just for Diego.
I want to evaluate you.
Yes, evaluate, please. This is a left upper lobectomy in 86 years old patient with a central tumor, okay? Very fragile, everything is very fragile. Yeah, some hematoma on the artery and everywhere.
First mistake together. That was first mistake.
Okay.
The IDC yellow is also better. Never do together in IDC yellow.
I do it like 9 years, always, almost always together. This is the first time happened. Okay.
You don't do 86 every day.
Yeah. So after compression, Diego, of 30 minutes, okay, you will see what happened.
Can I ask a question to the juniors?
Yes.
It's a teaching course. Guys, during these 30 minutes, what do you do in your theater? You have a major bleeding eye disease. Huh? Apart from praying and God you want, what else do you do?
Diego, this is the final after 30 minutes of compression. This part of the wall.
Good, what else?
Now, as for blood, and then if you're going to go to surgery, you need to eat it.
I have to do the thoracotomy tray open, yes, okay? What else?
Also, you make sure that you have a major vein access in case you have major lines in case you
Right,
have
so
like
who
rapid
needs to
transfusion.
stop chit-chatting and needs to wake up? Because we have a potentially major problem, what else?
Would you suture this one? No. Yeah, I think suturing in this one is to kill the patient. Okay.
So you put a Tachusil or
This is what I did. I finished the lobectomy. I put a Tacusil and glue and whatever I had, and asked someone to pray because I don't pray, and that's it.
You know, shit is the fun, what do you do? Right, so we need to go around the area, so now we need all the parts, we need to do the drums. All these things need to be in your brain, okay? Boom, 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 this is what Akora needs. This is what the theater team will need. Have the scrub nerves ready, okay? We need this.
So staplers are really good and help us a lot, and maybe there were no VATs without staplers, but they have their limitations. First of all, cost. Staplers are really expensive, and there are millions of patients, maybe hundreds of millions, that cannot afford buying staplers or pay for staplers, and they go to open thoracotomy because they can't get operated. Huh?
if you have no staplers, the officer will be poor.
Yes, yes, of course. This is this is
If you have no support for this.
this is the title of the surgery of the lecture. Does the stapler give us less trauma to the tissue or more trauma to the tissue? This is an important question. If you cut the parenchyma and suture it manually versus to just put two staplers, which one is less traumatic? Less traumatic. I don't know. I don't have answer. But I think with precise suturing, it could be less traumatic. I'm not sure. Stapler is amazing, but one of the problems of the staplers is make a generation of surgeons who are very technological depending. I mean, if I take a random sample of 10 residents from around the world, maybe I will find 7 or 8 of them never put a stitch on the lung, and they don't know how to stitch the lung. So for everything, there is positives and negatives. Economic speaking, it's a stapler a business is a huge business. Look at the number, 7.3% of annual growth rate. I mean, we will reach 2030 with annual investment in stapler more than $6 billion, which is a huge number. This is a small sub-Saharan country in Africa called Liberia. Very beautiful country. I hope I visit someday. With less than 6 million people living in there. The annual budget of the whole country is $500 million. So imagine, using the industry of staplers is 10 folds more than the economy of the whole country. This video, or this picture, maybe Diego remember very well. We went to operate in Gaza. It was 4 years ago. And they had no stapler. We had to take the staplers with us to operate. Okay? So we took our luxurious instruments with us. But if you think about the people or the surgeons who are living there without staplers, you cannot blame them to do a thoracotomy, right? This picture, who knows what is this device? Huh? Yeah, it's water seal. Have you ever used it? Where? In England? In England you use it? No, where? Spain? Okay. Well, this is operation room, and this is ICU. Can you guess where is this? It's not in Gaza. It's not in Gaza. It's not in Africa. This is in Europe. This is in North Macedonia, which is a European country. Okay? These places cannot afford staplers. They cannot afford a monitor for the ICU. How they can afford the stapler? This publication was published by a Greek group. It's about economical crisis a couple of years ago. They stopped to use staplers because of the economical crisis. So they back to the thoracotomy and do everything open because of the lack of the staplers. By the way, this might be happen soon if something happen about in the Middle East and this area. Okay. So the developing countries, many of them, they don't have the luxury to use staplers, and this will make the adoption of VATS will be slower and maybe not possible in some countries. Okay, so that means that they have two options: or stay in the open thoracotomy and do everything in open thoracotomy without going to the next step, which is VATS, or maybe to find some solution. So the idea of mixing between thoracoscopy and not using a stapler, it could be a little bit weird for somebody who has the stapler available in his bed, in his room, and for another countries or another people, it could be a brilliant idea. So in this concept, we use, instead of stapler, we use polymer clips, stitches, suturing, knotting, all this stuff. But it's good. Is it good to use these techniques? Well, first of all, it should be cost effective because you save a lot of money in each surgery. I believe that you can save more lung tissue by not putting a stapler, and I will show you why. And very important is the surgeon skills. I mean, teaching the residents and even yourself, practicing suturing and knotting and clipping every day may make you a better surgeon, and you keep your skills. Well, so I will skip this slide. This is a small study. I did like a couple of cases without stapling, and this was my results. The operative time was acceptable. I mean, not too much different from the stapler operation. I had one conversion, I have to say, to be honest, in these cases. It was because of bleeding, but not at the same area of the clip. Okay, so let's see this video. This is a wedge resection. This is a nodule, very peripheral nodule. I decided to do it without using a stapler. If I was going to take a stapler in this, for this wedge resection, call it, I'm sure that the amount of tissue you have to take out will be much more. If we re-sterilize harmonic 10,000 times, it's not expensive. You can. You can do anything, but I mean, this is how to describe, this is just to describe the staplerless technique. I mean, to do things without stapling. So just suture the area. Okay. This is another example. It's a pediatric surgery for 2 years old patient with a sequestrated lobe. So for some reason I decided to go in this surgery also staplerless. So first I have tied the aortic branch, the sequestration branch. Okay. Then after cutting the sequestration branch, I went to the vein. The vein was also tied at the same way. By the way, in pediatrics, sometimes you cannot put stapler bypass, and tying is much more easy. So this was the vein. Artery. The artery was done. The basal branch is separated in the segment 6. Now the A6. And for the last step in this surgery, I used the stapler for the bronchus. So I did the whole surgery with only one stapler for the bronchus. Okay. This case is a segmentectomy. It's a basal segmentectomy, also without stapler, opening the fissure with the harmonic. We found the basal segment, basal trunk. Then another basal branch. Here, dissect the pulmonary ligament. Then you get to the vein. In this case, I did branches of the basal segment one by one. So the vein is done. And now the bronchus. The bronchus was cut. The basal bronchus. Then suture. Then we check the margins of or the borders of the basal segment, and we did the segment margins with the diathermy by this way. All the segmental plan was done by the diathermy. Then the important test was at the end of the surgery, is to see if there is any air leak. So there was really no air leak, zero air leak. So to conclude, this technique may have a lot of disadvantages, but it also may have a lot of advantages. It's a low-cost surgery. It's enable us to keep our skills, encourage to teach the residents also to have their own skills in tying and suturing and so on. And it's avoid the surgeon's technology dependence, and that's it. So to conclude, initial experience shows that this kind of surgery is possible, and you have to be with experience before trying to do this stuff. Thank you so much. No question, please. Yeah. Yes.
When I think about this lecture, I always think that technologies here make us our life easier because at the end it's true. We grow dependent from technology. Usually when you're doing a molectomy or a appendectomy, you have a vessel that is easily tied. 95% of the time right now, I use it. By the way, it's true is that you have to be able to know what to do when you don't have the stapler, only or when you are not able to get the stapler. That it will happen sooner or later. And I also think that teaching right now is probably the same because the resident learns what you're doing, or what you're comfortable doing. And you usually use a stapler for a vessel that can be easily tied. Then when they have the same case, they will also use a stapler because they will say, well, it is what is done. So I think staplers are amazing, make our life very easy. The technology that they have developed are usually making us much easier handles and much easier passages for these kind of things. But we have to remember that sometimes we might not have it. Sooner than later, as you're saying, some crazy guy will do something that will render stapler covers around the world stop. We have to know what it is.
Yeah, that's exactly what I mean. This is the message of this lecture. I mean, technology is amazing, and it pushes the limits more and more. But maybe some days we will not have these technologies. So it's important for us to keep our skills. And maybe after 10 years, you will not do a surgery. Maybe the AI will do the surgery instead of you. But this will not make a good surgeons. I broke the stapler. I broke the gun of the stapler, and it's open. It didn't open. It was blocked. Then I just cut below the. I put another stapler below. Then I get the wedge, and that's it.
Was this sterilized stapler?
No, new one. And it went to Johnson & Johnson, I think in Belgium or somewhere, to check, and they said, no, the stapler is okay, nothing wrong with it. Yeah. No, they checked the line of the, yeah. How did? Where, in the segment?
Yes, in this case you said that you didn't have air leakage in that case.
Yeah.
But usually when you need to do,
I mean, I've done this several times. I mean, not less than 10 times to do the segmental plan with the diathermy. I almost never have air leak. If you do the segmental plan correctly, you will not have air leak. Sometimes minor air leaks you can suture. More questions? Thank you.
So for our last lecture, a very unknown surgeon that nobody knows who he is going to talk about sleeve resections and the journey that has been minimal invasive surgery right now between uniportal bats until uniportal rats.
okay, so I will talk about the complex cases by minimal invasive sleeve, double sleeve, by UVATs and by URATs. I want to show you what we are doing and what was our evolution. Since we did the first lobectomy in 2010, we have evolved to more complex cases, and now we are able to do everything by single hole. We were evolving to different techniques in the last years, and now we reach a moment that the robot is here to stay, and we can make everything easier compared with the VATs. So different techniques to deal with complex cases, like suturing the vessels, like this kind of technique. I think I agree with Firas that every surgeon should know how to suture. I think we should do maneuvers like tying, suturing. Apart from the technology, we should learn how to do this. I think it's one important message that all thoracic surgeons should learn how to do it by VATs instead of opening the patient. If you don't have the staplers, or if you don't have clips, or if you don't have some, so try to learn how to tie, how to use this technology is important, because in some parts of the world we have nothing. So I used to go to Africa very often, and I need to learn how to deal with complex situations with no technology, and this depends on us how to learn this. Another thing important is the control of the main PA. In case of difficult hilum, prevention is important. Don't let the opportunity to bleed before controlling the PA. So if you have a difficult dissection, my recommendation is try to control the PA before a disaster. So I will skip these complex things, just to mention that most of the cases can be performed with a sleeve. Most of the central tumors, you can save the lung. So the rate of pneumonectomies is very low in expert hands. When you see a surgeon with a high rate of pneumonectomies, I'm sure he's not doing the best. Because I always say that even you have no experience with a sleeve, you can always open the patient. It's always better to open the sleeve than VATS pneumonectomy. The problem is some surgeons are obsessed with doing, VATS, and they think that everything should be finished by VATS, and it's not true. The most important is to make a good surgery, and this is why I think, in my opinion, sleeve is always better than pneumonectomy, which is kind of aggressive operation and should be selected only for few cases. Of course, I do pneumonectomies, but I do very few. So initially, sleeves, we do run interrupted sutures. I was trained in lung transplantation for many years, so my training was with the interrupted sutures, and then when we started to do VATS, we selected a running suture. Different kinds of sleeve, I will skip this. The most important is to master the technique of the sleeve. There is a specific technique for a sleeve. Especially, we develop a way of doing, it's called non-grasping technique, using the suction and using the needle holder for a running suture. And it's important to master and to learn some tricks. For example, when you have a left upper sleeve, I think it's very useful to retract the PA. This trick. You fix the posterior pleura and you retract the PA. So these kind of small tricks are details that helps your surgery. Making a good retraction, you can see, this is a small detail, maybe just enlarge ½ centimeter the surgical field, but it's enough to have a better exposure. So in surgery, small details make big steps, small tricks. And now you can do, because in this particular case, you can see how it's so difficult to suture the artery. Normally, I don't grasp the tissue, except when I do vascular sleeve. And this is why we develop some instruments. You can see the forceps we develop with the scanline. The curved forceps is very useful for the artery, because for a vascular sleeve, you should pick up the edge of the artery. It's not like a bronchial sleeve. In the bronchial sleeve, you can retract with the suction, but with the artery, you should not do it with the suction. You should pick up the edge of the artery and then this is why these kind of instruments are very useful. Another important thing when we do a sleeve with a running suture is to create a tension at the end. So when you do a running suture, at the end, you can use the hook just for this maneuver. But these are very, very important details that you should always do it, just to create tension in the posterior part of the anastomosis. Otherwise, if you don't do this, you can lose the tension and then could be dangerous. So always when you do a sleeve, at the end, use the hook just for pulling the thread, and now you can tie. When we have tumors on the second carinal, we can save the lung. This is called spiral lung surgery. We don't need to do a lobectomy, or we don't need to do a pneumonectomy, of course. That some patients, I receive patients like this that they offer pneumonectomy for them in another centers, which is crazy for a carcinoid tumor localized endobronchially. So you can remove the tumor, typical carcinoid, and you can cure the patient without lung resection. That is the idea. So you need to master the technique. The most important thing is to do a lymph node dissection first on the subcarinal area, just to make clear the subcarinal space, and then to identify the limits of the bronchus, first step. And then you have to identify the right upper lobe bronchus, the right intermedius bronchus, and just cut for the reconstruction. You can see here, we remove very close, so we cut more. Huh? It's very close the margin, so we just need to cut more to have a clear margin. Huh? And now the next thing is to create a second carinal reconstruction. So, first, intermedius to upper lobe, and then after we create the second carina, we join to the right main. In this case, we will join to the right main carina. So it's a second and main carina reconstruction. Super challenging. Because this patient has a positive margin on the carina. I will show you now. Here. So, these are very nice tricks to retract the vagus nerve and to have more space. But you can see here. Here, we see the margin is positive, so we need to enlarge through the carina. This is the left main bronchus here. So we need to cut the left main bronchus, and we need to cut the trachea here. So we are removing the carina completely. And now the challenge is to put this into this. Yeah? And this is why it's so important, the experience of the surgeon. You can see more distance from the carina, short distance from the second carina. You need to put the stitches far in the carina and short in the second carina. And there's no mistakes here. There's no mistakes because, you know, we are with the tube on the other side. So you should, if I puncture the balloon, could be dangerous. Okay, now we adjust and we do the, at the end, this is very important, okay, don't forget. And this patient keep the lung, no lung resection, and free of tumor, free margins. With the robot, I think will be easier. Well, this is a BSL. For example, when you have a tumor on the intermedius, or sorry, on the left main bronchus, you should approach the sleeve from behind. If you have a tumor on the second carina, you should approach from the hilum, from anteriorly. This patient is a pure tumor on the left main, so from behind it's quite easy. I will show you one trick. This is one trick on the left side, very important trick, to retract the vagus nerve and to enlarge the space in the subcarinal area. Now we pass the bronchus here, the left main bronchus. And I will show you another trick that can be useful. That is this. We enlarge the margin here because it was too close. This is a little bit more than left main bronchus because you see the upper and the lower are almost separated. So it's almost second carinal. You can see here are separated both. Not totally separated, but partially separated. So we are joining first the one part. And now we join these two here. I want to show you one trick for retraction. I think I did in this case. Is this? Yes. This is a very nice trick for the traction of the lobe. No, this is not. This is the suture. I did this, for example. You can also do this. You can put a stitch on the lung and fix anteriorly. Look. Maybe here. Here, you can see? You put a stitch on the lung and you fix anteriorly to the chest wall. So you can have a traction of the lobe. You don't need a grasper, like this. And now you have more exposure. And now we do a just left main reconstruction. So from behind is fine. Even this spacing is almost second carina, but from behind is fine. When we have this is one reinforcement. When we have a second carinal, you should do it from anteriorly, and you should do retraction of the PA. So that means like this. Cut the left main bronchus, cut the upper, cut the lower, and join the 3 tubes. Tumor on the second carina. Also, some surgeons will do pneumonectomy in this patient, which is crazy for me. And here you can see how we do all the dissection, all the lymph node removal first. We don't cut anything, any vessel. Just open the fissure. It's very important to open the fissure for vascular control mainly. And now here, you can see we dissect the PA, the left lower artery, and then we do the trick of the retraction again, same, like this. It's very important to remove the lymph nodes to make clear the anatomy. We fix this to the posterior wall to make traction on the PA. These are small details, but that enlarge a lot. And then we cut the left lower, we cut the left main, we cut you can see the tumor there. It's a carcinoid tumor as well. Another retraction, and then we can join. First, I like to join the left main to the left lower, and then after that, the left upper. This case by robot is much easier. I have several cases with the robot doing like this on the left side, but I didn't edit the videos, and it's much easier. Because the maneuvers for suturing are easier. And you have to do several running sutures in order to avoid and then check the inflation. Yeah, this is another case similar. This is a middle lobe. I will skip this case. Remember? I don't remember this case. Yeah, it's a middle lobe. Middle lobe sleeve should be managed from behind. Okay? When you do a middle lobe sleeve, my recommendation is to manage from behind. I mean that we do the middle lobectomy, and then from behind we do the anastomosis. So you do everything from the hilum, but then you do the anastomosis from behind. It's important, from here, from behind. This patient, I don't remember the case, let me check. Yeah, it was close to the 6, the tumor, so you have to reconstruct the 6. You see, they are almost, these are the difficulties. When the tumor is very low, sometimes you need to remove the 6, or reconstruct like this case, but you have to be careful because the 6 is very small, and it's very easy to close. But this case, again, with the robot is easier, no doubt.
Can you just explain, Diego, what you mean by from behind?
From behind, because you do from anterior, from the hilum, the lobectomy, but the anastomosis, you should do it from the posterior part. Not from anterior, because you have the artery. No. Yes, you do the lobectomy from anterior. Below the artery, you dissect everything. You can even cut, but the anastomosis you should do from behind, not from here. Retract the artery and do it from behind.
You can put just a loop on the artery.
Yes, like this. In this case, I think we didn't put vessel loop. Oh yeah, we put. Because if you try to do anteriorly to the artery, it's very difficult, because it's below. It's difficult. So, like this, it's like bronchus intermedius sparring lung. Not especially difficult. For double sleeve, when we started, we use running suture. Sorry, we use a clamp. That was the first case reported in the literature. But now we use tourniquets or even better bulldogs. This is what I mean. When you do a artery, you need to pick up the artery, and this is why we have designed this instrument, just for vascular sleeve mainly, because you should not do it like the bronchus. The bronchus, I use a suction. For the artery, no. You need to pick up to adjust the edges. So it's important to be precise with this. This is just a double sleeve where we have to put a clamp because it was too proximal, intrapericardial, and then we do running suture with 5-0, 5-0 Prolene. And you have to be more patient with the vascular anastomosis because no mistakes. You know, if you make a mistake and the artery starts to break, then you have a problem, especially if it's proximal. So, very delicate with the movements in vascular anastomosis and no mistakes. And this is the way we put the clamp, because you can see the tumor is very proximal. So in this case, tourniquet is not safe. You can see here, too proximal. And so how to put a clamp? If you need, you can put like this, outside the wound protector. And you should fix the here with a tie. You should tie here to avoid someone or accidental opening. This is a case that not possible sleeve because 3 branches here, not possible end-to-end sleeve, so we have to do a lateral reconstruction, which is more difficult in my opinion, because so you have to do it like this in the other direction. It's more easy. This also to show you a double sleeve with a huge tumor. This is not double sleeve, this is bronchoplasty and vascular sleeve. And then again, you see when there's a discrepancy, you have to go here more far and more close here. And it's very important to retract the artery, to pick up the artery, to adjust the edges. And always at the end, we always release the distal first and then the proximal. One of the characteristics you can see here, when you don't put correctly the bulldog, the tourniquet, could happen this, a leak. This is why I prefer nowadays bulldogs, even for VATS. It's safer. And the edge of the artery is better. This pacing is difficult because, it was we removed the 6, so the caliber is very, very discordant. You see the main PA and you see the basal artery, very big discrepancy here. Look, small artery here, big artery here. But very good result. And also important to be careful and be patient and keep calm when you have a bleeding after the tourniquet release. So the key is keep calm, don't be panic. Just see the hole. I have some videos where I don't see the hole, I reclamp again. So if I don't see the hole, I will not put blind sutures. This is the most dangerous thing, blind sutures. So every time I put a stitch is because I see the hole. If I don't see the hole, I will not put blind sutures. So I will prefer to reclamp the artery. And then put the stitch. You can see I'm using the Angel-Raff technique. With the left hand, with the suction, I compress the artery. It's very important because you remove the blood and at the same time, you compress a little bit to have less bleeding. So it's important. Keep calm and have a clamp next to you always. Because the disadvantage of the tourniquet is that when you open the tourniquet, you cannot reclamp again. This is the disadvantage. You need to pass another tourniquet. On the right side, also vascular sleeve, I will skip this. For tracheal cases, I will show you different ways. Jet is for carinal resections. Jet is my favorite way. After tubeless. Tubeless is my first. But tubeless, you need a good anesthetist to manage tubeless. But if not, jet ventilation is very ideal. If you have the machine, it's perfect. But you should have the jet ventilation machine. Not every hospital has the jet ventilation. But you can see it's more easy to suture compared with a tube. If you have a tube, interfere with the suture. But you have a jet, this is a bronchoscopy. We inject jet through the bronchoscopy. And then now we join, after the right upper lobectomy, we join the intermedius bronchus here. And we do several stitches. And then at the end, we release the pericardium because it was a lot of tension. And then we put thymus flap. I only do this in some tracheal and some carinal resections. I don't do, or if I do a sleeve or pneumonectomy after radiation, I will cover the stump, but not for a normal sleeve. Just for covering the... also carinal sleeve pneumonectomy under spontaneous ventilation. This is my favorite thing. This is the extended adenosis carcinoma. And we do right carinal sleeve pneumonectomy. You can see trachea, left main bronchus. And the patient is breathing spontaneously. You can see here how the patient keeps the saturation. 94%. With the trachea open, with the bronchus open. Some people say, how this is possible? Because the patient breathes through the incision. Like a patient with a tracheostomy, how they breathe through the incision. So it's amazing. We have a lot of experience with these cases in Guangzhou. You can see we finished the carinal pneumonectomy, and the patient has 97, 98%. Also, we did in Peru, we did a tracheal resection and reconstruction with no intubation. The patient was breathing spontaneously. I took my anesthetist after Mexico last year, from Mexico, from INER, a very good surgeon, a very good anesthetist, expert in non-intubated, and we did this case in Peru. Of course, you need to manage a lot of things. How to, you need to block the vagus nerve, you need to block the airway with bronchoscopy before starting. Every part of the airway should be instilled with lidocaine. So, vocal cords, vestibular, first part of the trachea, second part of the trachea, left main bronchus, right main bronchus. This is very important from the beginning. Spray. With the bronchoscopy, in every point. And now you can see, this is a very complex tracheal resection because this patient has a stenosis very distal on the carina, and then identify the stenosis with the needle. And now cut the stenosis. You can see it's on the carina because you can see the right main bronchus, the left main bronchus is almost separate. And the patient is breathing spontaneously. It's amazing how it works. Of course, you should be very careful with the hemostasia, very careful, no bleeding, okay? But you can see, it was a young patient. We operate with my foundation in this case. The patient has no resources, and so we did in Peru, in Lima last year. And the patient did very well. You can see, it's a long distance. We cut more, and then we do the anastomosis. So it looks science fiction, but it's real, and it works very well. The patient keeps saturation all time, very good saturation. The patient is moving the diaphragm, and is breathing through the incision. So for me, it's easier to do the anastomosis, because I have more space to work. And then we join the trachea. Very difficult because, you know, it's almost separate left main bronchus and right main bronchus. So this is the left main bronchus. So it's quite challenging case. Quite challenging reconstruction because, you know, we are reconstructing the carina. Almost. And then here and the patient keeps saturation all time with no problem, and the postoperative outcome was excellent. She left the hospital in the 5th day, very happy. So this is why tubeless is the best technique for tracheal and carinal. But of course, you need a good anesthesiologist who master the technique, not for every anesthesiologist. But if you master the technique, believe me, it's the best for the patient, for everything. Because this case will be very difficult with intubation. The trachea of this patient was 5 millimeters, very small. So you cannot intubate this patient. This is another case of a sparring lung tumor on the carina, and then we just did, it was a lot of adhesions because it was a patient in India. In India, all patients have adhesions, all. So it's typical because TB and a lot of problems. So important to do a good hemostasis. We remove the ascicus and then we cut the tumor with no lung resection because it's just a pure tumor on the carina. And then we do the reconstruction left main bronchus to the trachea first, and then pass the tube, and then we join the right main bronchus here. So you have to use several running sutures. We have a very good team of anesthesiologists in this case. And at the end, very good result. Se volvió loco. ¿Sí? No. No.
Something we find.
What?
We believe on covering the bronchial sutures with something.
For what?
After using do you use, do you do it? Do you believe on it? And do you do it on the parts?
No. I only do for carinal.
Yeah.
Carinal cases or after radiation. If not, I don't do it. Even I don't cover the double sleeve now. I used to cover at the beginning, double sleeve, and since years, I don't cover. Also in Pulmonary Hospital, nobody covers now. After hundreds of cases, they told me that there were no difference. No need.
Can I ask you a question?
Yeah.
When you do these non-intubated cases, do you have any complications like bleeding? Do you intubate straight away, or do you
Like bleeding?
Yeah, if you're doing like a partial resection, and then it's not intubated, and they start bleeding. Does the protocol do you intubate straight away, or do you
It never happened to me, but if you have to intubate, you should put the tube through the incision. We have a tube ready always. We can intubate the left main bronchus easily from the incision, no problem. This is why you have to be very careful with anastomosis, with the hemostasia, very careful. This is the bronchoscopy of this patient. Very good result. You can see. We did anastomosis on the right main bronchus almost, and we removed completely the right main bronchus. So it was a very good result. The bronchoscopy was excellent. This is almost on the carinal sleeve pneumonectomy. This case, I will show you one trick, how to retract the aorta. If you want to have a more traction, you can use this trick for the aorta retraction. Like this. But the carinal pneumonectomy on the left side depends on the anatomy. It's the anatomy dependent. Some patients are possible, most of the patients are not possible. So very few patients are possible to do left carinal from the left side. I mean, with guarantee. I mean, you can do a good anastomosis. This patient was impossible. We cannot even see the right main bronchus. Even with the traction of the PA, it was very hard. So what we did was to the right side, and we did bilateral UVATs, and we did anastomosis from the right side. So trachea, right main bronchus, remove the tumor, remove the left lung first, and now the anastomosis of the trachea and right main bronchus. It's not especially difficult because it's like a right upper sleeve lobectomy. More challenging, second carinal resection from the left side. More challenging when you do a sparring lung and you don't remove the lung, like this case. So we did right side first, and now we do, this is patient under ECMO. I think for this case, ECMO is suitable. Otherwise, the other option is sternotomy, because with intubation, normally I think it's unsafe, very unsafe. But with ECMO is good. So we just now cut the right main bronchus, cut the trachea. You can see the tumor inside. It's an amazing picture. Look, left main artery completely dissected. This is the bifurcation of the artery. Right main artery, left main artery. Very difficult to see this image. Very difficult. Because we dissected previously before from the other side. So now we do the lymph nodes, cut here. And now we just do the anastomosis. You can see left main bronchus, right main bronchus, trachea, and we do the anastomosis. It's a very amazing image, this. See the left main artery here, crazy. And now trachea to the left main first, and then right main to this neocarina. Same as we do carinal. But then, you know, in the last year, robotic surgeons say that the robot is better visualization. I agree with this. But the problem is you need 4 to 5 incisions because the robot has 4 arms. How can we do this? How a uniportal VAT surgeon can go back to 5 holes or 4 holes? This is not ethic, in my opinion. It will be, I cannot sleep if I go to do 5 holes because just playing with the robot. So this is why I never like it, the robot. No, it's not, I always like it, the robot, but I didn't like it, the idea of doing 5 holes because I will consider not doing a good practice. So in 2016, Intuitive contacted me to develop this. They came to Shanghai, all the engineers, and then they told me, do you want to lead this project? Yes, say, of course. And then I went to the United States and I started to develop this robot with them. In secret, I remember they told me, don't tell anyone they're doing this, okay. And then the only choice was to do subxiphoid, subcostal. And then we went to there several times. One time Mahmoud came with me and we did the first cases, the first lobectomies in Calabar. We published. It was okay, but we saw some limitations because, you know, it's cable driving, the robot is cable driving. The technology of Da Vinci is made by cables, as you know. I guess you know how it works, a robot. No? Everybody knows how? Maybe not. The robot, the Da Vinci, is made of cables. Maybe you will think that it's a huge technology, but it isn't. It's a simple technology. It's cables that pulling and pushing, like this. And this is how the arms move, pushing. This is how it works. No sé cómo se dice en inglés, poleas. Poleas. Polish. Polish. Okay. Now this is how you can explore a robot. When you see a Da Vinci, you will see that there are cables. And the cables push and pull. And this is how the robot moves. This is why, Leonardo da Vinci invented this kind of movements, like poleas. So it's a very primitive technology, but very good for the robot. It's perfect, but has limitations for single port robot. So I was not convinced. So what happened? During the pandemic, I was locked down at home 3 weeks in Spain. And in my hospital, I have the Da Vinci Xi. So I have a lot of time to think. I was 3 weeks doing nothing. Because in the last 10 years, I have no time to think. I was all time in the OR working. But 3 weeks playing with the robot, I said, well, let me play with the robot. I started to play with the Da Vinci, and I saw that, okay, I can do 2 ports. So I changed the configuration of the robot. I did some tests, and then I knew that, okay, I can do camera in the upper part, left arm, right arm. So by doing by portal, I can do. So I was very happy with this because wow, I can do it. I can use 2 ports. So for me, this was acceptable. So I did 3 cases with 2 ports, but after 3 cases, I was feeling bad because I was doing something more invasive than before. And I want to do the best for my patients. So then why not uniportal? So in September 2021, I changed the configuration of the robot, and we did the first case in the world of fully uniportal robotic surgery. I mean, fully rats with robotic staplers, everything controlled by the surgeon in the console. And this was a milestone, because after this, we opened a new chapter. That robotic surgery can be done for the first time through a single hole. And we started to do cases, we started to develop the technique. Of course, at the beginning, we have, learning curve, difficult angles, a lot of difficulties, like a uniportal VAT, same. I went to Colombia, remember, the month after that, and we did the first case with VAT staplers, which is, is the same, but the surgeon put the staplers to the incision. So I started to define the configuration. We did the publications. On the right side, we use 2, 3, 4, and on the left arm side, we use 1, 2, 3. And we established this configuration for all cases, very important. We published all in the literature. We started to perfection the technique to make it easier, better. We developed new trocars. I developed these new trocars without intuitive, because they didn't want to support me. When they knew I was doing uniportal with XI, they become crazy because they wanted to sell the SP. And then if I teach everyone in the world to use XI through a single hole, nobody will buy the SP. So they were very afraid because they will lose money. Because uniportal is cheaper. Because with XI, we save a lot of money. We use only 3 arms, 3 instruments, not 4. So in every lobectomy, we save 1,000 euros compared with multiportal rats. Plus, less invasive, less painful, etc., etc., etc. And then I developed a new version, which was cutting the head. I was thinking how to improve, and then these are the normal trocars, because these are transoral trocars, which are very expensive. Each one is 4,000 euros, each one. So it's not available for everyone. Not easy to find. So what we did with these trocars, we removed 1 lateral part. But I was thinking how to improve with the normal trocars. So I have the idea to cut the head. And if you cut the head, becomes like this. If it becomes like this, you can move with freedom, and you have more space to work. So there's no collision at all. So I think the difference that the robot is very good for I cannot move the videos now. Something wrong. No, I cannot move the videos. Now. So, and we started to do more and more cases, carinal cases, all kind of sleeves. I think for these kind of cases, the robot is very useful because, the movements you can have are, compared with VATS, easier. I cannot say to make a better surgery. I don't think that robotic surgery is a better surgery than VATS surgery. I don't think that. What I think is make easier. You make everything easier. If you are a good VATS surgeon, you don't need the robot at all. You don't need it at all. Maybe for 1% of the cases you will need it, like, high location of, you want to suture. I have one case of paraganglioma, we injured the subclavian, and I have the robot and I suture from here, uniportally. With VATS will be almost impossible. But it's one case that maybe with VATS you are very limited. But in general, everything you can do with VATS, you can do with the robot, or vice versa. But of course, for the artery, you have more facilities for suturing when we do double sleeve. Initially, we do double sleeve with tourniquets. Now we do double sleeve with bulldogs. And you can see this patient walking 24 hours after the operation, 24 hours, with very good results, outcomes. No pain, you can see the patient 24 hours after a URATS double sleeve. And then we also use the bulldogs now. This is my favorite tool for double sleeve. Intrapericardial, normally we do double sleeve intrapericardial. You can see with the Maryland we go very fast for the dissection, very fast. And you can do a very good control. You can cut very easily with the scissors. I think there's no doubt that the robot makes easier, especially this part. The vascular anastomosis is much easier with the robot. The movements, everything. So this is the main benefit, in my opinion. It's another case I will skip. This is a case. This is an interesting case, very unusual. Sleeve segment 6 segmentectomy. A patient with a tumor at the entrance of the segment 6. So instead of doing left lower sleeve, we do segment 6 segmentectomy. Very, very rare. Important to remove the lymph nodes first. As you can see, we open the fissure. And it's fully robotic with VATS staplers. There's no fissure, so we open the fissure from anteriorly. And what we are going to do is to cut the segment 6 and to join the basal to the left main bronchus. First, we open the fissure from the hilum. And now you can see the tumor is at the entrance of this S6. So first we do the segmentectomy of the 6. And now we just remove the lymph nodes. Important, remove all the lymph nodes before starting doing anything. This is the vein. And now for the bronchus, we cut. We do some tricks, you see, for the traction of the artery. This is a very nice trick, you see. And now we cut this is the left lower bronchus. Again, it's gone. So I will go fast and then skip the slides, yeah, because it's failing all time. No. No, no. Doesn't work. ¿Cómo, cómo?
Vaya una caja aquí que no está funcionando, entonces habría que pasarla desde casa.
Pues nada, acabamos entonces. No puedo enseñar. I cannot show you the best things of the lecture, but try again or not? No. So I wanted to show you my new robot, the Surrui. What we did with the Surrui is amazing. But not possible. No? 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 Oi! Hey! Hey! Don't move! Don't breathe! ¿Ah? ¿Cuánto tiempo tengo para que no falle? 5 minutos. Venga, va. Okay, I will just finish here, showing you the last part of the anastomosis. You see, well, it's a basal. These are very nice tricks. Okay. So, left main bronchus, tracheal resection with the ECMO, or with this is a very high located tracheal resection, very difficult. And for this we use ECMO, because the location was very high. You can see here how high it is. Very high. With VATS, it will be difficult this case. I did some like this and it was difficult, the anastomosis. With the RATs, easier. We use barb suture for this kind of cases. This is with jet, and also challenging, but the carinal sleeve pneumonectomy from the left side with rats, rats. I think it's possible, but not all the cases are possible because, it's very challenging. You can see how we identify the left main bronchus, the right main bronchus, the trachea. This is from the left side. And here, this is the bifurcation of the right main. We cut more because it was a positive tumor. We have a microscopic only positive margin on the right side, trachea free, because it was ACC. In ACC, sometimes you have to leave positive margin and give radiation, because it's impossible to cut more, too much tension. And this is almost the intermedius and the upper. And you do with the running suture, with the Biloc, a very good case, did very well. So, second carinal, I will skip this, and this is why my new robot, I'm working with this company since few years, developing the real single pore robot. This robot is made by Nitinol. This is a revolution in thoracic surgery. It's the best robot in the world, with no doubt. This has as you compare with the speed, this is the Da Vinci, and this is the Surrui. It's 10 times better in everything. The payload capacity, the movements. Look the comparison. This is the SPI. 45 degrees, only angulation. Look the Surui, angulates 90 degrees. It's amazing, it's another level. One limitation of the SPI is that only needs 10 centimeters to start working, 10, it's huge. This is why it's very difficult to do through the chest, impossible to do through the chest. You have to go subsifoid, which is ridiculous, it's no sense. And should be only 4 centimeters. And a lot of advantages. We did the first cases in China, in a clinical trial. I did very challenging cases with the Surui. I will show you here. The first cases I did in Guangzhou with the Hejinsing. You can see it's a very small, I developed this trocar for them, for thoracic. It's a trocar very small with 2 arms. We cancel 1 arm, we don't need the 4th arm, only 2 arms on the camera. And the assistant works below. As you can see, it looks like we have 3 holes. Look the arms. The angulation of the arms is amazing. For suturing, for everything. And the assistant put the staples to the inferior part, like this. This is a middle lobectomy, also subsegmentectomy. This is, for example, one case where you have a tumor in between S2 and S3, what to do, lobectomy or bisegmentectomy, no sense, S2 and S3. So we do subsegmentectomy, S2B plus S3A. You see the docking is very fast, it's 5 minutes, 2 minutes, it's very, very fast. And then we do subsegment. Just to go into the subsegment. You have to learn segments before, you cannot do it if you are not expert in segments, of course. But we do hundreds of segments, so we know the anatomy very well for this kind of cases with the reconstruction as well. And then we do subsegmentectomy with the Surui. You can see the arms. It seems that I have like 3 or 4 holes. Angulates a lot, it's really amazing. Also sleeve, we did the sleeve with the Surui, several sleeve cases. I did right lower sleeve. In my YouTube channel, I think we have few cases. I don't upload too much cases recently. I have no time, but I uploaded some bronchoplasty cases with Surui, and the angles for the for the suturing with this robot is amazing. And this is just the first version. We have a even better version. You can see here how we do the joint to the intermedius, to the middle of bronchus, and how my assistant helps from down. You see, the assistant helps with 2 sections. And even more complex vascular reconstruction. So the future is here. I think we have a lot of things. The next year, a lot of robots are coming. I think it's amazing what we are facing. And we have more options, more robots on the market. We need more competition. Otherwise, Intuitive will control us. And we should not be controlled by any company. We should be independent and decide how to operate. And I want to show you my foundation. This is a project that we started 2 years ago. And we created a mobile unit for the first time in the world, mobile unit dedicated to minimal invasive surgery. We already did the first mission in Ghana. It was 2 months ago. It was a historic moment. For the first time, operations can be done in a mobile unit, minimal invasive, thoracic. And we did very complex cases in Africa. And it was very successful. We were very happy how we, parked the mobile unit next to a hospital, and then the patients are coming to the mobile unit, we do the operations, and then we send back to the hospital for the recovery. Because, the mobile unit should be compact. I would love to have a big mobile unit with 2 hours, but it's impossible. You cannot move in Africa. You should think about a mobile unit with all technology, solar panels. I invited the chief of Pulmonary Hospital to come. He was very happy to be part of this historical moment. And then we finished 3 cases, and now we are ready for the next mission next year in Sierra Leone, Ivory Coast, maybe in Angola. We are deciding the place. That's all. Lunch.
more lectures?